Fall Lung Committee meeting. Next slide. I want to begin, as always, by welcoming new members that we have to our committee. Dr. Beatty, Dr. Patel, Dr. Puri, Dr. Setha Ramu, thank you so much for joining, and we look forward to your participation. Next slide. We do have a really exciting and packed agenda today, as we always do. I just want to put this up here. We have 3 presentations today. We also have about 7 polling questions, and then you'll hear from all of the investigators about updates on all of the trials. I'm going to begin with just a very general update for you. Next slide. And the first is from Dr. Albane. Dr. Albane chairs the SWOG Clinical Trials Partnership. To remind everyone, this partnership is part of SWOG, but it's the non-federal component of SWOG, and that it runs industry-supported trials. Again, no federal fundings, but it is an opportunity for us to do other important trials that we all feel are important within the SWOG platform. So this is a very, very important, but yet still developing program. And Dr. Albane asked to show you this slide. And if you have any industry contacts that you think would be a good partner for SWOG, again, work with someone that would be interested in working with us under this new platform. If you could let us know here, you can see the email address here. And if you need any more information, please also visit the Hope Foundation. I will tell you that we are in discussions. We won't be presenting it today because we're in very early discussions about using this mechanism for one trial, and you'll hear about that most likely at the spring meeting, but we have started to use this as an opportunity, and I think we're excited to have this opportunity to have this partnership in addition to our regular federally funded partnership. All right, next slide. So accruals. Now, we all know that it's been a very, very challenging, I would say, and an unimaginable year that we've had. But despite that, you'll see here that our accruals to clinical trials is really increased from the previous year. If you look at the July 2019 to June 2020 versus the same time frame the year before, we are at 250 versus 181. So I think that goes to the amazing job that the whole lung committee and the whole lung cancer community is doing, particularly in this such an exciting time with all these exciting new agents that we have and that are really making a difference in patients' lives, but still a lot of work to do to continue to move forward. So I want to again thank everyone for accruing to the trials. Next slide. And we've also been very busy. We had a really busy year, and in terms of publications as well, we made this a major priority for us this year to really focus on getting out our publications. And you can see here that we have many, 1, 2, 3, 4, 5 that have been published or accepted for publication. Most of these are just recently. We've got a couple more that have been submitted, and we're feeling good about those as well. And then we have several that are pending submission. And again, there are others that are a work in progress as well. So we've really been doing, again, a great job in accruing, a great job in, again, completing the trials and publishing results of the trials. Of course, that is so important to get the information out to the public and to our patients and to the rest of our physician community as well. So congratulations to all the hard work here, because everyone knows this does take a big team to get this done. Next slide. I do want to alert everyone to the abstracts that we did just submit for the World Conference, which will be virtual in the end of January. And I just want to point out that these are our translational medicine abstracts. And so a huge thanks to all of you to submit the tissues and the blood. I know this adds, again, additional work to the trials, but it is so incredibly important that we have these specimens, both the blood and the tumor. And so this is why we do this, again, to move this field forward biologically, which we can then leverage in the therapeutic arena. And so we have three, they're all coming from the lung map side. A wealth of information with so many patients on the screening studies, as well as the patients on the actual sub-studies. I'm not going to go through these, but looking at really relevant issues, tumor mutational burden, next generation sequencing, correlation between ctDNA and the tissue analysis. So these, I think, will have a impactful presence at the World Conference. All right. Now, I do just want to share with you just some general updates. Not sure if you've seen any of this, but just thought I would just take a moment. Many of you probably did see this August 2020 New England Journal paper that really looks at the effects of these treatment advances that we have made in lung cancer in really the more perhaps more optimal way, looking at incidence-related mortality. And again, not to spend too much time here, but if you look at this red line, and I'm not sure if you can see, if you can actually see my cursor here, but the red line, you can see that we actually have decreased mortality here at a higher rate, 6.3 versus 3.2, again, for both men and women here. And that when you look at the trends in the 2-year overall survival going from 26 to 35 and 35 to 44, and that this is really felt to be due to treatment advances here. You can see this is when EGFR TKI came on the scene. And this is just an example of how the therapeutic advances is really, really improving survival and decreasing mortality. And so with that, going to the next slide, I wanted to share with you some headlines from ESMO, which was just last weekend. And I just picked a few high-level headlines. The first here, again, to the point of targeted therapies, decreasing mortality, as well as these curves, the next time we see them, should look even better with immunotherapy. But here's the results, the high-level results of the CROWN trial, which looked at lorlatinib versus crizotinib. PFS is the primary endpoint. Obviously, no surprise in this data with this hazard ratio of 0.28. But what this means is that as lorlatinib will move to the frontline setting as well as its other TKIs, how are we now going to optimize these agents and what's going to be the best sequencing here of all of these agents? I think this is a really, really important question, as well as of course, combination. So I think this is great, but yet it's now also a dilemma as well. What should we use first? What should we use second? And so forth. The other very exciting abstract was the abstract on AMG 510, which is now sotorasib. And we heard at ASCO a few years ago that 5 out of 10 patients with non-small cell lung cancer had a objective response. But now we see a larger number of patients, 59 patients, and the response rate here is 32%. That is still a highly respectable response rate here, and that the progression-free survival is 6.3 months. This was just reported in the New England Journal of Medicine this week as well. So again, adding another actionable driver mutation with a highly efficacious drug, we're so excited for as well. The next Again, I just have a few of these. I do think it's important to see the 5-year results. Again, just me able to say we're looking at 5-year results, I think in and of itself is a dramatic step forward. But here's the results of the Keynote 024. Remember, that was pembrolizumab in patients versus chemotherapy in patients with PD-L1 expression levels greater than or equal to 50%. And you see that that 5-year rate is about 32%. It's double that of chemotherapy. For the first time, you know, the question, and Roy was the discussant here, are we really curing these patients? And, you know, it certainly looks like we are curing a subset of patients, so time will tell. And then finally, just 2 more top headlines, the next slide, is the LungArts trial. You know, I think every day in Tumor Board, we address this question about should we give post-op radiation therapy to our patients with microscopic N2 disease or N2 disease. And so after they've been resected. And this trial did not show a benefit for PORT in completely resected. We're not talking about R1 resections or other issues, just completely resected N2 patients. So there was no benefit. Obviously, though, radiation therapy does decrease mediastinal relapse rate, but interestingly, it did show this higher rate of death in the PORT group, and there was this higher rate of grade 3 for cardiopulmonary toxicity. And I'll leave the radiation colleagues on the phone to weigh in on this trial in the radiation session as well. So overall, no benefit here. So I think we can answer that question. And then finally, just the update from the ADAURA trial, now showing this really substantial decrease in CNS metastasis here for the patients who received osimertinib versus the patients on placebo. And the entire ADAURA results were just also published in the New England Journal of Medicine. Congratulations to Dr. Herbst, who was the plenary speaker at ASCO for this study as well. Okay. Let's go to the next slide. All right. So as I've already mentioned to you, we've really had I would say, stellar year here in terms of publications, but also in terms of activations. Not sure how many of you saw the front line in July to where we were the premier highlight. We, the Lung Committee, had activated 6 of 7 trials within 2020, of course, and in the face of COVID. And I just want to say thank you to, again, our superb protocol coordinator, Gretchen. Thank you so much, and the entire operations team as well, our amazing statistical group, Mary and her team, all of the investigators that really made all of this come to fruition. So when you're going to hear about all of these trials momentarily, but that I have to say is unprecedented and very, very onerous for all of us. But this is why we do it, and just a high level of enthusiasm for all of these trials. And we're so excited to accrue to them and get them all completed. All right. So again, thanks to the entire team. It truly is a team. Thanks to Judy, our patient advocate, as well, who really gives us great input on our trials to make sure that they are trials that our patients will want to engage in. All right. Next slide. Okay. This is just a very high-level overview. As I mentioned, you'll be hearing about these studies momentarily. Oops, I guess there must be a little animation here. If you can click again, there you go. All right, so the maroon boxes are SWOG-led trials within the cooperative group. And I think that you can appreciate that we really do have trials across the spectrum of not only lung cancer. We did just have our mesothelioma trial complete its accrual, and then we have our ongoing trial in thymic carcinoma. As well, here's the rest of the portfolio, partnering with Alliance ECOG and NRG. And you'll hear about those trials as well. All right. Next slide. Oops, sorry there. Okay. So I think since COVID has really taken over everybody's lives, our patients' lives, our lives, and I felt that for lung cancer, this issue is so much more important, obviously, because of the pulmonary infiltrates that can occur. I thought we should start the day by talking about COVID and lung cancer. And the perfect person to do this is Dr. Fred Hirsch. He really immediately rallied a group of investigators together and formed this COVID lung cancer consortium that has been meeting every other Tuesday for many, many months to really talk about COVID, talk about the science, talk about the patients, talk about the clinical trials. And he was just awarded a U54 looking at COVID and serology, which he'll talk to you about in a minute. So Fred, thank you so much for your hard work that you've done on this, and we look forward to your talk. So Fred, if you want to unmute, you'll.
My slide here has disappeared. I am scared what can happen over the next slide, but let me try to come through it anyway. COVID lung cancer consortium came by very early in the pandemic situation, and I had an idea. I made it together with Jhanelle and Paul Bond that we need to bring together the community to discuss emerging issues for lung cancer patients, and also to invite people from different institutions to discuss how can we collaborate on the research in this field as quick as possible as was needed. And it ended up that we made a community. We meet every second week. Many of the people around the table here or around the screen is participating. We have participations from several academic institutions. We have participation from patients' advocacy organizations. We have input every time from FDA leadership, from NCI leadership, and it is not only the lung cancer community, but we have also expertise from the virology community. So everything came together, and we have had amazing time together talking about opportunities and talking about how to tackle the situation together. So that is, I will focus on a couple of projects which has come out. I will say the U54 has come out of this. The other project I will talk about is a different international project. Next slide. Next slide. Oh. I have some disclosures, advisory boards, and research funding. That doesn't work very well, Karen, technically. Can I have the next slide? First of all, TerraVault is a global project. It went out from Italy, and Marina Terracino in Milan also Leora Horn from here put together a database and collected information from patients with lung cancer who has contracted COVID. And this Teravolt database expanded very, very quickly and include all continents today. It was presented data a few days ago at ESMO. Next slide. Next slide. Altogether, more than 1,000 patients from 20 countries has been registered and analyzed. Most of the patients are from Europe, and we can see here the demographic distribution. Next slide. Next slide. There you go. We can see here that most of the patients have non-small cell lung cancer. There are fewer small cells, and the distribution, most of the patients were in stage 4, 65%, and all the details are described in the presentation we can get from ESMO website. Next slide. Can someone try to get my slides a little bit quicker? I apologize. What is the outcome of this Teravolt? There are several parameters, but most strikingly and most frightening is, of course, the death rate. 32% of the patients died, and they died of COVID according to the clinical assessment. They didn't die of lung cancer, progressive lung cancer. And this is frightening, and this has already made attention many places, including NIH, which I will come back to. Next slide. The conclusion is clear. I will go quickly forward. Oh, I use a lot of time with this. Can someone help me to get it a little bit quicker? Karen, can you, is there anyone you know?
I don't think we can, Fred. I think there's just a little bit of a delay there. I'm sorry.
Okay, I don't know how to move this forward.
They will move it for you.
Yeah.
But I think there is about 2 seconds or 3 seconds delay. Sorry, Fred.
Okay. Here we go. So Dr. Ned Sharpless, the director of NCI, had gave an interview in ASCO Post September 12th, that is close to 2 weeks ago. And he focused clearly, he said, for example, patients with lung cancer and those with hematologic malignancies seem to have worse outcome, which is not surprising, but it paid attention, and we had to make a focus on lung cancer. Next slide. Next slide. So here is a background. Please go back. There. Here is the background for our project. As we know, the coronavirus has several proteins: spike protein, envelope protein, membrane protein, nuclear protein, and they all produce an immunologic reaction, particularly, of course, antibodies and cellular immunity with T cell response and cytokine response. Next slide. This is a paper quite recently published from Miriam Merad and her group at Sinai, and the paper described all the cellular reactions to the coronavirus, I can recommend taking a look at this paper. Next slide. So we have focused on the antibody response, and there are several subtypes of antibodies. And antibodies are generated through a response to the proteins. Most important seem to be the spike protein. And we can see here there are several subtypes and several titers of the different antibodies. Next slide. These are, Mount Sinai was an epicenter for coronavirus infection. Fortunately, we are not any longer. I would like to see the same success in terms of reduction of infection, of course, other places. But we have a lot of patients and we have a lot of donors, and we had an infrastructure to bring all these things together and look into different aspects of the COVID, the SARS-2 COVID infection. Next slide. We looked into antibody response for PCR confirmed donors and clinical suspected donors, and we made an analysis, not me, but my colleagues did in different groups at Mount Sinai. Next slide. They also looked into antibody response, the magnitude, when did the response come, and we are following these donors also in terms of duration. But we can see here that there is, as expected, a rise in antibody titers before the screens. We can see the days, 7 days up to 35 days. We can see here how the antibody titers raised, and this is just a background data for what I will talk about in the project. Next slide. We also know that the immune response seems to correlate to the aggressiveness of the disease. It has been demonstrated on the cellular response. It has been with the cytokines. It has also more recently been shown in terms of antibody response. Next slide. This is an illustration from a very nice paper from my colleague, Rob Samstein, and his group published in Cell, where they clearly demonstrate here, it is a review paper, and we can see here that the virus RNA is, of course, decreasing over a short time period, but the antibody response is increasing and the cellular response equally. The question is now, how long time will the antibody response increase, and how long time will it be sufficient for protection? Next slide. So we raised a very simple question in our grant application. Do lung cancer patients have a different antibody response compared to healthy individuals? Can that contribute to explain why lung cancer patients have such an aggressive course of COVID? And that is, of course, one component of it. Might be a complex picture. Next slide. So we responded to the RFA. We did that very quickly over 5 weeks. We worked day and night to put together a team of lung cancer oncologists and world-famous virologists. And we worked together to try to address those questions. And we had 2 simple projects outlined. Project 1, study the magnitude, the quality, the durability of antibody response to COVID-19 in patients with lung cancer versus healthy individuals. And the second project was a preclinical in vitro project where we are studying cell lines and preclinical models. They are all characterized, they are all lung cancer, of course. They are all characterized with different biological characteristics, and we are looking how does the different cell lines, different models, and different biological characteristics associate with viral infection. And that is done in the lab of Adolfo Garcia Sastre, which is a world-famous virologist. He is also the member of the National Science Academy. Next slide. So we are studying 1,000 newly diagnosed lung cancer patients, all stages. We know that over the next 5 years, many of them, might be 60, 70% of them at least, will be vaccinated. That gives us an opportunity to study the vaccinated lung cancer population's response to antibody response to the vaccine. If they have the COVID infection, of course, before we will catch that in our cohort as well. The study starts in 10 days, so everything has gone very rushy. What is a control population? The control population is 1,000 so-called healthy individuals. We take them from the Mount Sinai lung screening program. Of course, they cannot have lung cancer. That will exclude them. So, and we are also working with the GO2 Foundation, which is a partner in this grant. And the GO2 Foundation has a network of lung cancer patients and also probably healthy individuals where we can find younger people. Of course, we are not only looking into lung cancer versus controls, we are also looking into how is those lung cancer patients will be treated. So we have an opportunity here to associate the antibody response to treatment, to age, to ethnicity, to tobacco history, etc. We do antibody assessment at time of diagnosis, 3 months, 6 months, 12 months, 24 months. All the serology analysis will be done in the lab of Florian Kramer. Florian Kramer was the first one, I think, to develop an FDA-approved ELISA-based antibody test with a very high sensitivity. And he has been in the media many times. You probably know the name from New York Times, Washington Post, and TV. So he will analyze all these samples. And in terms of lung cancer patients, we are open for if someone will participate, we can have that communication. We want to do this as quick as possible. We will also study the cellular immunity assessment, T-cell, B-cell, cytokines, and that will be a separate project in the whole scenario. Next slide. and that is the last slide. Next slide. This is a complex structure. As I said, it went out of the COVID Lung Cancer Coalition, and it has investigators. We can recognize John Mina, Paul Ban. We can recognize Dr. Rolfo. We have virologists from UT Southwestern. We have from Sinai, Philmax, Dr. Gomez, and we have Yushir from Vanderbilt is our biostatistician. And of course, we have advisory boards. And last but definitely not least, our partnership with GoTo Foundation, Amy Moore has been a part of this from the early beginning. So we are very excited about this project. It was definitively funded this week. We got the NOAA, and we are ready to run from October the 1st. So Karen, with this, I think I made it within 20 minutes, and hopefully we can follow up on this over time, and hopefully we can get more collaborators to this as well.
Yes, thank you, Fred. Thank you, Fred, for that outstanding presentation. I do want to take a moment to see if anybody does have a question for Fred. We're certainly all interested in that clinical trial, Fred. And I just have one quick question. You know, this is a gold mine to do some additional sub-studies once you identify, you know, patients who do have COVID, comparing those that don't. Are there other planned sub-studies that are you collecting a lot more information that other sub-studies could be performed?
Yeah, so our plan is beyond the serology, beyond the antibodies, as I said, cellular immunity is something we definitely will include. We want to include other sub-studies. If someone has any proposal, we are very open for discussing this. I think that is the whole idea from NCI as well. This is a lung cancer community effort, and they wanted to see that happen. One thing we are discussing with a company is, can we get a specific vaccine trial for lung cancer patients where we can embed also correlative science? And the company is very positive for that. It is Moderna, one of the companies which is leading the field. And NCI, we are in discussion with NCI. We don't have any definitive commitment on this yet.
All right. Thanks, Fred. That's an important piece of information for our investigators to think about as well. All right. Again, I want to remind everyone, if you're in the audience, to please use the chat function. And if you're not speaking, to please mute as well. So now we're going to move to our Community Engagement Subcommittee. Dr. Hesketh.
Good morning, Karen. Thanks very much, and good morning to everyone. I believe I have control over the slides. I would like to give everyone just a brief update on the Community Engagement Subcommittee. This was a concept developed and proposed by Karen back in late 2017 and was actually activated early in 2018. Initially, we had 4 members of our committee. In addition to myself, we had Suzanne Cole, Alex Mentor. We had our very dedicated patient advocate, Judy Johnson, as well. And Gretchen Getz has been superb in supporting us from our inception. And then later, we've added additional members, Jeremy Kilburn, Dan Carrizosa, and most recently, we've been very happy to add Nadine Husri from Yale. So I think the charge that we received from Karen was really to try to enhance the overall mission of the Lung Committee by getting our community-based oncology members more involved and more engaged. And our responsibilities really that were defined at time of inception were really to provide input during the clinical trial development process, to be able to help review trial designs to ensure that they meet community expectations. Very importantly, I think try to identify potential barriers to successful trial execution. Importantly, also serve as champions in the community network and to participate in monthly calls and at least until this year, in-person meetings that we typically held at the group meetings. So in terms of activities, we have been doing monthly calls. And again, in prior years, we've been having in-person meetings. One of our first activities was really to develop a survey that we wanted to send out to a list of folks that we identified as community-based oncologists that had been linked to the lung committee. I think we found some very important findings from that survey. I just highlight a couple here. We clearly identified, I think very importantly, that we needed better engagement. We found that really our community oncologists really were not terribly well linked with the lung committee. The majority rarely attended group meetings. And I think, what we're learning to do now with these kind of virtual meetings, I think to me, hopefully going forward, will be something that we can employ even when we get back together as a way that will give greater access to community-based oncologists who may not be able to attend the meeting in person. There was clearly a view from our community oncologists that overly rigid eligibility requirements were the most common factor that limited trial enrollment. I think, as everyone knows here, there have been some very important recent initiatives that I've been very fortunate to be involved with ASCO and Friends of Cancer Research and NCI, where we've really made some significant recent progress in broadening eligibility criteria on NCI clinical trials. And interestingly, there was a very strong interest in having study-specific patient educational materials, and this has become a priority for our group. So we also, very importantly, try to provide input during protocol development and also to participate in accrual enhancement efforts. So in terms of activities that we've been involved in, basically during protocol development, one of our members is assigned to each new protocol at the time of approval by the lung committee. And so we try to be involved in every step of protocol development, including submission to SWOG triage, submission to CTEP during the protocol development process, and also very importantly during the activation process. So currently there are 6 SWOG trials that are either active or in development that we have one of our members that are assigned to at the present time. So in terms of our accrual enhancement efforts, we're very excited about a potential partnership with the MedNet that we are working on right now. I suspect that for many people in the audience, they're familiar with the MedNet. It's a physician-only web-based community that tries to provide expert commentary on real-world clinical questions in oncology. And the MedNet was established by our most recent addition to our committee, Nadine Husri and her husband, in 2014, and currently has in excess of 11,000 oncologists participating. And this group received a SWOG Hope Foundation grant to raise awareness for 2 SWOG clinical trials, S1418 and S1501. And this really was a very successful effort and clearly increased engagement among oncologists out in the community. And the results of this pilot study were presented last year at the NIH. So we're planning currently to try to partner with MedNet to have an outreach to all of the NCORE sites. And we will be particularly trying to highlight the 2 recently activated phase 3 trials by the Lung Committee, S1914 and S1827. So we also actively participate in accrual planning meetings for the active trials. And we're also very excited about an initiative that Wendy Lawton is leading, which is trying to develop plain language clinical trial summary documents for ultimately every SWOG trial. And I think very excitingly, the first SWOG trial that Wendy has developed this plain language document for is S1914. So we're very excited about that because I think that will help in terms of disseminating information, not only to clinicians, but also to patients. So we also participate in protocol presentations to the NCTN's accrual core team. So going forward for the future, I think we're also very excited about an initiative in which we are going to be trying to develop a list of SWOG-affiliated community oncologists who have an interest in lung clinical trials. And this list will be limited to oncologists who have to affirmatively respond to an invitation. So everyone on this list potentially will get an invitation, but they have to respond to that invitation to indicate that they are indeed interested in receiving information and queries periodically from our group. I think it will provide, hopefully, a cohort of individuals that we can solicit input on in terms of new concepts. Clearly, it will allow us to give targeted communications once clinical trials become active. And we can also provide this group with periodic updates as clinical trials progress. We also may use this group to try to determine why trials that are having difficulties with accrual may be having those problems. And I think as the activities of our subcommittee get larger and as we get involved in more clinical trials, hopefully this list of individuals would provide a potential source of additional subcommittee members that could actually be a very, very valuable addition to our group. We're also very interested in collaborating with the Digital Engagement Committee to develop a number of social media tools to enhance patient and provider education efforts in lung cancer trials. So, Karen, I think I've given you back a few minutes. I told you that I'd be less than 15 and get you back on schedule. And I appreciate the chance to talk to the group. And for any community-based oncologists that are in the audience right now, if you are indeed interested in being on this list that we will be reaching out to on a regular basis, please just send me an email and we'd be happy to get you involved in the process.
Thank you, Paul. And I just want to say thank you to you, your leadership, and the entire committee. I cannot sing your praises loud enough. You have done an exceptional job, and I think it's only going to get better with time. But to our community partners, we need your help, and we embrace your help. So please email Paul, please become involved. We are more than happy to have you. Again, it's such an exciting time for our patients and for everyone, and we want to move this as fast as we can for our patients. Ultimately, that's our ultimate goal. So thanks again, Paul, and thanks to the committee. All right, and next we're going to go into our thoracic surgery session, and Dr. Hofstetter will lead that session for us. Wayne? Let's see if he's, let's see. I'm not seeing him at the moment. Looks like we've lost Wayne. Maybe he had to run somewhere. Okay. I tell you what, let's skip this session for now. I'll email him and see, maybe he had an emergency come up. I'll email him and see what's going on. Meanwhile, can we move then to the next session, which I believe is our radiation. Roy, is that okay? Roy Decker?
I'm here. I'm here.
Oh, Wayne, you're there?
Sorry, I was not able to unmute. I wore a tie as a special occasion, so I am ready. Just frustrated at my ability not to be able to be heard.
Yeah, I'm so sorry. Yeah, I can't even see you up here. All right. Anyway, thank you for your persistence. Thank you. There you are. There you are. Okay.
Nice. So first off, thank you, Karen, and to the Lung Cancer Committee and to SWOG in general for continuing to promote thoracic surgery and lung surgery in general within SWOG. It's important to us. We as a group of thoracic surgeons are committed to being involved in multimodality care, and this is a great venue for us to all get together and discuss things in general. I want to give just a brief update of what's going on within SWOG clinical trials for involving surgery. So first and foremost, I think what's been very exciting recently is the ALCHEMIST trial is coming to full accrual in several of its areas. This is for stage 1B to 3A non-small cell lung cancers that are completely resected. They go on through a screening structure where they go through screening, and then depending on their outcomes of the screening would be eligible for certain arms. I do have a question for Karen or for the group as it comes up, is given the recent ESMO findings, is the crizotinib arm going to be changed, or because it's near full accrual, will it complete with crizotinib? And you can either answer that now or later. I'm fine with that. Here's what the lung screening schema looks like. And all of you know this. I think one of the more exciting arms that's been developed is with immunotherapy after completion of resection. I want to emphasize how important this is to surgeons in general. We've been frustrated over the last several years of recognizing that patients who are resected that have high risk of residual disease or systemic recurrence, that we're not able to offer them standard of care immunotherapy. Now, it's great that we have trials that are ongoing that involve platinum doublets with pembrolizumab so that we can prove that and then move on to platforms where we're giving patients prolonged immunotherapy, especially in those patients that we know have a high risk for recurrence. In this arm of the ALCHEMIST trial, patients will be one of 3 arms. They receive control, platinum doublet plus pembro, or platinum doublet with pembro, and then followed by maintenance pembro. This is just at its beginning in terms of accrual. Overall accrual for the entire trial, the screening trial is over 5,000. What a proud goal. We're proposed to reach 8,300. The allotment group, Karen, is almost nearing full accrual at 381 out of 450. As mentioned, the ALK arm of the trial, 118 out of 168. And the anvil was closed, and the ALCHEMIST chemo IO is just now opening, and something we really want to push for accrual in. So if you have availability, if the ALCHEMIST is open at your institution, please, please, please consider getting your patients onto that chemo IO arm, and so that we can push that accrual forward.
So Wayne, do you want to back up and I can talk a little bit to answer your questions there that you had?
Please, go ahead.
So we could back up to that last slide. So just to let everybody know that the erlotinib trial does continue on until the drug is FDA approved in this setting. It will continue on. And I will say that we are close to the goal of 450 with 381. So just to let everybody know that it is continuing on. And I am really pleased to see the accrual for the crizotinib trial. We have 118 out of the 168. So to answer your question, Wayne, this too will not change. It will go to completion with crizotinib. And of course, the question that's in the background here is certainly erlotinib and crizotinib are not the most efficacious drugs in this setting, but at the time there wasn't anything else, and just shows you how fast the field has moved forward, which is great. But nonetheless, I still think that this is a very important trial. Remember that these 2 trials do have overall survival as their primary endpoint. You know, I will say that well, take that back. We did change the crizotinib now to DFS. I apologize. You know, the erlotinib trial it will be a challenge to understand. For the data analysis of this trial will be a challenge, but nonetheless, I still think it's going to give us valuable information. And of course, I hope everyone is really opening the ALCHEMIST chemo IO trial. Again, you see that accrual goal of 1263. There are 12 patients on, but this is a really important question. Certainly, as we know, we'll be seeing results from Anvil before this trial completes accrual, as well as we'll be seeing results from the neoadjuvant setting. So it's still all very, very important, but the faster we can accrue, the faster we can get results here too. That are going to be
Karen?
Yes.
This is Roy.
Yes. Hi, Roy.
I agree with everything you said, except to point out that if, in fact, in the U.S., osimertinib gets approved in the adjuvant setting, it is going to be hard to continue that arm. But let's wait and see if that happens and if it gets reimbursed. It
will close once it gets FDA approved, Roy.
Oh, okay.
I think even though it's reopened, it is still a challenge, but I think we should do our best.
I agree, and I do think the chemo IO trial should have top priority. I think that's really, let's put as many people on that as we can.
I mean, we are so close. Remember that the important piece is to be able to analyze the data here. You know, 381 is good, but it's not the 450. So we really do want to try to, you know, get to that 450 for data analysis so that we have things that are interpretable at the end of the day. There's still value in this trial, in my opinion. All right. Thanks, Roy.
Okay, so I need to jump off here pretty quick, so I'm going to get through the rest.
Oh, sorry.
So thank you for those. Thank you for those clarifications. And I think that does underscore the need for us to be in this environment, you know, participate in quickly moving trials and get trials quickly through the hop here. All right. So of trials that were open, the resectable mesothelioma, this was S1619, this is successfully accrued. So that is now reached full accrual. This was a trial that involved chemo, pemetrexed, and with addition to atezolizumab for patients who had resectable mesothelioma. It's reached accrual and expected to read out within the next year to year and a half. So congratulations on that to ANSO and the group. Other trials that are in development, the NACIS trial, this is formerly TRUST-IO, and I'll talk briefly about a proposed trial. NACIS, which is the neoadjuvant chemoradiation with or without immunotherapy before surgery for superior sulcus tumors. We recently have gone through CTEP evaluation. This is what the schema was as you guys have seen it last. It involved giving chemo, atezolizumab, and concurrent RT in one arm versus standard of care, which was chemo RT in the other arm, followed by surgical resection and atezo for a year on the treatment arm. After going through discussion with CTEP, our primary endpoints have not changed. It's still pathologic complete response, and secondary is overall survival. But they felt that we did not have reasonable data to continue long-term maintenance immunotherapy in either arm. And so we've had to acquiesce, and the new schema is that the patients are going to undergo standard of care upfront before surgery, or standard of care with atezolizumab followed by surveillance. Again, that preserves our primary endpoint of response, and then we also get to look at overall survival in the endpoint. I will admit that I was a little bit sad about having to give up maintenance therapy at the end.
So wait, can I just ask everyone on the phone and in the audience about what they think about having to give up maintenance? I think we were all also sad about that as well, but because the primary endpoint with major pathological response, but this is also going to be the only trial ever conducted, and most studies do give the maintenance. I'd like to hear from others their thoughts about this. I know you have to go, but just a quick, anyone want to quickly give thoughts about that?
Karen, I'll just jump in and say I joined late, but I'm here now, so I'm happy to take any questions on this too.
David?
Karen, it's David. Can you hear me?
Yes.
Yeah, so I think it's not a wise decision to drop the maintenance in this. It really undermines the validity of the trial in terms of what we're offering to patients. There's no data whatsoever that just giving a short course will achieve what we want. So I'm in concurrence with you all.
Thank you, David. Anyone else want to weigh in? I mean, it would be helpful if more of you weighed in with that same thought, because then maybe we could go back to CTEP and have another discussion about it. So if you can weigh in, either why don't you weigh in on the chat function if you can? I know Wayne's got to go, so I'll let him complete his session here. But let us know, or email me or Ray, because we all feel the same way about that. Thank you.
Yeah, I think we'd appreciate that feedback. Last one, I really don't need to go over. I can go over within the committee. This was a proposed trial for metastatic osteosarcoma, open versus thoracoscopic surgery. And I think that as we go through the process, I can review that with the entire committee later on. So that really completes what I have right now. I'm happy to take questions, but at a different time, please send me an email or give the questions over to Karen or Ray, and I can address them at that point. Karen, thank you very much. I'm going to jump off to another call and be back briefly.
All right. Thank you, Wayne. Appreciate it. All right. So now we're going to move to the thoracic radiation session. Dr. Decker is going to moderate this session.
So thanks very much, Karen. We have a number of radiation studies to present, and then a few SWOG champions to present studies that they are encouraging enrollment on from other cooperative groups. I apologize for not making a slide that specifically addressed lung art, and I applaud Karen for bringing it up. I'm just going to say very briefly, and my colleagues can disagree, that it's very difficult to justify the routine use of port after we see the results of this study, although there probably is a place for it in some specific high-risk situations, and those should probably just be discussed in a multidisciplinary forum. But it's very interesting data. I think, let's see. So next slide, please. So we've got 3 active studies, and I'm going to turn the podium over to our 3 PIs for this. So next slide, I think it should be Megan Daly. And Megan, it's all yours.
Okay, can you guys hear me okay? All right, this is SWOG-NRG S1914, a phase 3 randomized trial for early stage medically inoperable non-small cell lung cancer, comparing radiation alone to radiation with atezolizumab. Go to the next slide. So why this trial? SABR, or SBRT, is the standard of care for early stage medically inoperable non-small cell lung cancer. And as we all know, the rates of primary tumor control are quite high, but regional and distant recurrences remain unfortunately common. And chemotherapy is frequently not well tolerated in this typically frail patient population that tend to be elderly. The immunotherapy is a particularly appealing strategy to improve regional and distant control without adding appreciable toxicity. And we recently conducted a phase 1 single institution trial demonstrating that immunotherapy is safe and well tolerated in this setting. Next slide. This is the schema for X1914. This is a phase 3 randomized trial. Patients on the experimental arm will receive 2 cycles of induction of atezolizumab and will initiate SABR with cycle 3. They will complete a total of 6 months or 8 cycles of atezolizumab before going into follow-up. Patients on the control arm will receive standard of care SABR, and we allow a variety of standard SABR options over 3 to 5 fractions. Atezo is delivered a Q3-week cycles. Next slide. Our primary objective is to compare overall survival in this patient population between the experimental and control arms. Secondary objectives include progression-free survival, both investigator assessed and by blinded independent review, distant local, regional, and local failure rates, and frequency and severity of toxicities between the 2 arms. We also have quality of life endpoints. Next slide. Briefly, eligible patients will have biopsy-proven stage 1 to 2A, as well as limited T3 patients. We are not, unfortunately, able to enroll patients with multifocal tumors or those with pericardial invasion, but tumors up to 7 centimeters can be considered if, in the opinion of the treating radiation oncologist, they'll be able to achieve appropriate dose constraints. And patients must have at least one high-risk feature suggestive of an elevated risk of recurrence based on tumor diameter, tumor SUV, or tumor histology. Patients should have no evidence of hilar or mediastinal nodes, and they need to be medically or surgically inoperable, or they need to have clearly documented their unwillingness to undergo surgical resection. And they need to be staged by PET CT and chest CT. Next slide. A few highlights and key points. First, this is a very common malignancy, and the proportion of lung cancer patients being diagnosed with early stage disease is gradually increasing with increased implementation of screening. These are patients who have a relatively poor prognosis and a significant need for better therapies. We believe that this trial has a fairly pragmatic design. The SABR fractionation is at the treating MD's discretion with a range of acceptable fractionation schema. Importantly, we are not using a placebo control, which we think should be very appealing to patients. We are delivering only 6 months of systemic therapy, which was also meant to be a pragmatic decision. There are several other trials in this space that your institutions might be considering, and they all require at least a year, if not 2 years, of systemic therapy. So we do think our trial design should be appealing to patients. And the timing and schedule is based on preclinical data from our translational medicine chair for the study, Dr. Artem Anjazeb, that suggests increased synergy between SABR and immunotherapy with our schedule, with 2 cycles of upfront immunotherapy before initiating SABR. Next slide. And so finally, just had one question for the audience. If you are not planning to open S1914, could you give us an idea of why not? Whether it's because of a competing trial, if you don't feel that you have the appropriate patients, or other. I would add, there's limitations to doing these polls in the audience, so please feel free to drop me an email if you have other concerns about the study that are keeping you from opening at your institution. The study team would be very happy to try and address these if any institutions have specific concerns.
Thank you, Megan. Everyone should be seeing the polling on the right side of their screen. It looks like we have about 2 more seconds here, and then we'll see if we get an answer here. So this is our first time doing this, so bear with us. Meanwhile, you can also chat with us or unmute. Let's see. Okay. How do we get the results? Here we go.
No answer was the most common response. 2% competing trial, 3% other. 1% don't have patient population. So everybody pretty much has it open.
What we want to hear.
It might be helpful to show the schema while you have the question up if you want to try and poll. That's just a suggestion.
Oh, all right, Karen. So everybody has it open, but we don't have very many patients on. So do people on the panel or in the audience want to give us some input about that? Are there some barriers that we're not aware of, I guess?
So I do see a few comments in the chat.
Okay.
They're pretty specific things that I might need to address by email with specific investigators.
Okay.
Some of the language in the consent form and so forth. So I will reach out to some of the people who are messaging me in the chat individually.
Okay. All right. Well, thank you all for opening it. That's great. So now we're really excited because we know we're going to get lots more patients on. Okay. Next, Roy, I'll turn it back to you.
Okay. Thanks, Megan. I just want to say of the competing trials, Megan has come up with by far the best design, and I mean that in that it's the most patient-friendly, short course of treatment and no randomization, no placebo. And it's also the most likely to get a great result. So really a fantastic study. So our next presenter should be Chad Rusthoven for the 1827. I see you're on, Chad. I'll turn it over to you.
Yeah, thank you. Are you able to hear me okay?
Yes.
Okay. Yeah, thanks for the opportunity. My name is Chad Rusthoven. I'm a radiation oncologist at the University of Colorado, and I'm presenting on this study, SWOG S1827, the MAVERICK study. And this is a study for patients with small cell lung cancer, both limited and extensive stage disease. And it's a randomization to MRI surveillance alone, plus or minus PCI. And for the sake of being concise, we don't have a background slide in here, but basically, as everyone's aware, PCI has been the standard of care for a long time in small cell lung cancer. And this standard has recently been questioned by a small phase 3 trial in Japan, looking specifically at extensive stage patients. It suggested in the context of MRI brain surveillance that PCI was not associated with an improvement in overall survival. And the reason for that may be that in the context of close MRI surveillance, we're able to catch brain metastases a little bit earlier, and we're able to offer effective salvage therapy. And so if that's the case, if we're able to salvage these patients effectively with active surveillance, we may not need to be delivering PCI for all these patients, and that may spare them toxicity to cognition and quality of life. Next slide. So here's our schema. And so if we start on the left here, this trial includes patients with small cell lung cancer. And again, it's a study looking at both limited and extensive stage disease. As I mentioned, there's a recent Japanese trial in extensive stage that looked at this question, that provided contradictory evidence to a prior European study. So we have contradictory evidence regarding the survival benefit of PCI in extensive stage. And there's never been a study like this in limited stage. So we have no data on a comparison of MRI brain surveillance plus or minus PCI for that population. So both of those populations are included in the study. And then the other inclusion criteria are straightforward: no brain metastases at diagnosis or after completing first-line therapy. And then patients are randomized to brain MRI surveillance alone plus or minus PCI. And the primary endpoint of this study is overall survival. And it's truly a non-inferiority design. Our hypothesis is that in the context of brain MRI surveillance, when we're able to catch brain metastases earlier, that there will be no overall survival benefit with the addition of PCI. And we also hypothesize that PCI will be associated with more toxicity to cognitive function and quality of life. If we go down to some of the bullets at the bottom here, this shows the brain MRI surveillance schedule, and it's every 3 months for year 1 and every 6 months for year 2. And this follows identically the schedule of the Japanese study. And it's also consistent with the contemporary NCCN guidelines. So obtaining these MRIs should not be an insurance issue for that reason. When patients develop brain metastases, the treatment of them is recommended with radiation, but the technique for treating them is left to the discretion of the treating investigator. So whole brain radiation as well as SRS are allowed. There's been some data recently on SRS that suggests that may be reasonable for some patients. And so this study actually allows you to offer SRS if you're interested in the context of a clinical trial. So that may be attractive for some investigators. Also, hippocampal avoidance, PCI, and whole brain radiation are allowed. We understand that there's a lot of interest in hippocampal avoidance now as a strategy to reduce toxicity. And it's very possible that the question over the next number of years really could be MRI surveillance plus or minus hippocampal PCI. So these strategies are allowed by the NCCN, and we allow them on this trial, and we track that prospectively for pre-planned subgroup analyses. And then the last point is that this trial is really designed to be pragmatic with the lowest possible barriers to accrual. So really any strategy that you would want to use for the treatment of limited or extensive stage patients is acceptable, and those patients can go on this trial. And so basically, this trial was designed to be a good option for really any patient that you would think about offering PCI to. So we really tried to limit the barriers of accrual for this study. Next slide. And so now that the study is open, really our big focus is accrual. So again, this is a non-inferiority study, and that requires a lot of patients to answer those types of questions. And so much of our focus now is trying to engage investigators to see if people will be willing to open the study at their center, and to keep it in mind when they're talking to their patients. So some notes on that. The study was activated in January, and it's open across the entire NCTN network, including the 4 US groups, and then recently it was activated in the Canadian group, and we're now waiting for local Canadian sites to open it. So we're very excited about that. The accrual now is actually 12 of our planned 600 analyzable patients, but we really need to ramp this up and start to accrue regularly on the order of 10 to 11 patients per month. So that's our big focus. This is our status as of last week. So 123 sites are fully open, with 460 pending. These numbers are a little bit inflated because multiple centers will be recognized as an opening under a given PI, even if not all of those sites are actual accrual sites. So here we have 16 NCORPs, 40 academic centers, 19 community centers, and we're excited also. We're trying to make a push to really engage VA investigators, and we have 8 sites that are either open or in the process of opening at the VA. Next slide. We've tried a number of different strategies, and we're actively always looking at ways to increase our outreach and engagement for accrual efforts. So as I said, the study is casting a wide net and open at a center near you. And we've also really been focusing on trying to engage NCORP and VA sites. We have a dedicated VA study champion, which I think may be a first for the one group on this study, Dr. Drew Moganaki, who's a well-known thoracic radiation oncologist at the Atlanta VA and Emory. If you're on this call, you probably received 1 or more emails from me asking you to consider opening this trial. So thank you for putting up with those. And we're working with the Community Engagement Subcommittee on some strategies via the MedNet, and also with the SWOG International Committee to try to open this at some international centers, which would be very exciting. Next slide. And then we want to acknowledge some barriers, because again, accrual is the name of the game here, and it goes without saying there have been some disruptions from COVID, both to the administrative processes and as well as to just patient accrual on trials. So I won't belabor that point. There are some competing trials that that we want to acknowledge too. There's an NRG study that's looking at PCI plus or minus hippocampal avoidance. That study actually completed its accrual successfully, but they also got an amendment recently to add something on the order of 80 to 90 patients. So that study will probably be open for another 9 months or so. But it is encouraging that study has accrued over 300 patients. So people are very interested in the PCI question. They're very interested in strategies to reduce cognitive toxicity. And it's quite possible that hippocampal avoidance PCI could emerge as the standard of care from that study. And again, our study does allow hippocampal avoidance. So if you do have the CC003 study open, I would ask that you consider, once you complete your commitment to that, to please consider opening this trial, because it really does ask the natural follow-up question. There's also a nice NRG study that's looking at the addition of a TESO that's open, that elected not to allow dual enrollments, and so that's an obstacle, but it's just our reality. So there are also some other barriers that we want to acknowledge. PCI versus no PCI can be a difficult randomization. In some ways, it's a little bit more of a difficult randomization than just the hippocampal avoidance question, because patients are able to elect for either of these strategies off study. And so our messaging is very important. So I just wanted to spend 30 seconds just focusing on that. When we offer this to patients, it's important to frame it correctly. PCI is the standard of care for limited stage small cell lung cancer. It's an NCCN Category 1 recommendation. And so if we're going to omit this therapy when we're treating our patients with limited stage, the best place to do that really is in the context of a randomized phase 3 trial. And PCI is also the historic standard of care for extensive stage, and we have conflicting randomized data showing an improvement in survival and no difference in survival in a Japanese population. And so a definitive study, i.e. this study, is really necessary to break the tie, so to speak, and actually provide definitive data on this question. And then again, hippocampal avoidance and SRS are allowed on the trial, and those can be attractive things to do in the context of a study, and you can do those things here. Next slide. And this is just kind of underscoring the points that PCI is a Category 1 recommendation for limited stage and a standard consideration for extensive stage, and that brain MRI surveillance is now considered the standard of care for all patients. And that's the backbone of our trial. Next slide. And so we have some poll questions too that we could try here as well. So this is the first question. Is it feasible to open the MAVERICK study and to enroll at your center? And we have 2 versions of yes and 2 versions of no. So I'll just give it a second for people to answer that if they would like. Okay, so a few answers here. It looks like most people say that the study is open or opening at their center, which is great, or that they would like to. And so if you would like to, please feel free to reach out to me or Gretchen. We'd be happy to work with you to try to open the study. So thank you for that. We have one other poll question that has to do with barriers. So what do you perceive as baseline barriers for enrolling on the study? Baseline preferences regarding PCI, competing trials, logistics of trial participation, and no major obstacles anticipated. And so while people are doing that's my last slide. And so after this, we can go back to the schema slide, and I'd be happy to take any questions that people may have. It looks like baseline preferences regarding PCI, and then competing trials are the top 2 potential barriers. But then that's actually the NCCN guidelines. We can go back. We've gone back to Dr. Daly's schema. That's okay. Roy, do we have time for the questions, or do we keep moving?
We could maybe ask one question, but we are getting short on time there. Chad, why don't we move forward? Sorry, Chad.
Yeah, no problem. Thank you.
Great job, Chad. I know we're about to open this trial. It's been moving at a very slow pace through our pipeline. So Our last SWOG-sponsored study, Dr. ALCHEMIST, to talk about the S1933. Rod, are you on, I hope?
Yes, I'm here. Can you hear me?
Yes.
Yes. My name is Rad Al-Jumaili. I'm a medical oncologist at the University of Oklahoma. So SWOG 1933 is a pilot study of hypofractionated radiotherapy followed by atezolizumab consolidation in stage 2 or 3 non-small cell lung cancer patients with borderline performance status. Next slide, please. So there is no data, no evidence-based data to guide treatment decision for patients with stage 3 non-small cell lung cancer with performance status 2 and stage 2 patients who are not candidates for surgical resection because those patients were excluded from randomized phase 3 studies that set the standard of care for this patient population. And most of these patients are treated with palliative intent with radiation only or sequential radiation followed by chemotherapy. There's good basic science and clinical data to support the synergistic activity of radiotherapy and immune checkpoint inhibitors. A randomized phase 3 study done at UT Southwestern led by Dr. Iyengar in the same patient population showed that hypofractionated radiotherapy was better tolerated than standard fractionation, and this study was radiation only. And we know from multiple studies that immune checkpoint inhibitors are better tolerated than chemotherapy in general with less treatment-related adverse events. Next slide, please. So compared to other solid tumors, higher percentage of lung cancer patients present with performance status 2, largely because of comorbidities, mainly heart and lung disease. And so this study looked at performance status as evaluated by providers and as perceived by patients. So if we look at this, performance status as per providers, 40%, about 40% thought that patients had performance status of 1, 20% performance status of 2, while when patients were educated and asked, 30% thought they had performance status 1, 33% thought that they had performance status 2. So we generally tend to overestimate performance status for patients, and we all see those patients in our clinics, and I think this study provides a good opportunity and potentially curative option, chemotherapy-free potential curative option for these patients, and provide an opportunity for us to have data in this patient population. Next slide, please. So our hypothesis that radiotherapy followed by atezolizumab consolidation in patients with stage 3 non-small cell lung cancer with performance status 2 or stage 2 patients who are not candidates for surgical resection will be well tolerated and will lead to better outcomes compared to historic controls. Next slide, please. So the primary objective is to evaluate the rate of grade 3 to 5 treatment-related adverse events in this patient population. Secondary objectives are outcome objectives, response rate, progression-free survival, overall survival, and all grades treatment-related adverse events. And with our communication with CTEP, the idea was to prove safety in this study and hopefully prove safety and signal of efficacy to run a randomized phase 3 study of this approach compared to what is thought to be the standard of care by CTEP, which is sequential radiation followed by chemotherapy. Next slide, please. So key inclusion criteria for step 1 before radiotherapy is stage 3 non-small cell lung cancer with performance status 2 or stage 2 patients with who are not surgical candidates. For step 2, after radiotherapy before atezolizumab, patients had to receive at least 45 gray of radiotherapy with no disease progression. And key exclusion criteria: active autoimmune disease, history of interstitial lung disease, or grade 3 pneumonitis or more pneumonitis. Next slide, please. So this is the schema, and as I mentioned, stage 3 or performance class 2, stage 2 non-surgical candidate get hypofractionated radiation therapy, which is 60 gray and 15 fractions, so 3 weeks, and then 2 to 5 weeks after completion of radiation, patients get repeat scans and no disease progression, then get to receive atezolizumab consolidation for up to 12 months. Next slide, please. So this is a pilot study, as I mentioned earlier, with the goal of proving safety. So small 40 patients study with hopefully a goal of running a larger study after proving safety here. And the observation of 8 or fewer grade 3 or more treatment-related AEs would prove safety, and so the goal is to screen 47 patients and enroll 40 patients. I didn't put that in this slide, but I got the CTEP communication end of August. There are 25 sites open, more than 150 sites is still in the process of opening the study. Next slide, please. So I didn't have a polling question, but my main question is any suggestions to increase awareness of about this study, any barriers to enrollment, and unfortunately, this meeting is not interact. I mean, we don't have a way of interaction, but you can use the chat function, or you can email me. My email's on the screen.
Thanks very much, Rod.
Thank you.
I don't see any comments here. So we will move on to the next slide here. Okay, so these are our SWOG champion studies. I don't know if they're all on the panelist call or not. Matt, do you happen to be here?
Hey, Roy. Yes, I'm here.
Oh, great. You want to present this real quick?
I'd be happy to. So my name is Matt Harkenreiter. I'm the radiation oncologist, and I'm the SWOG study champion for ECOG Akron 5181, a follow-up trial to Pacific, which randomizes patients with unresectable stage 3 non-small cell lung cancer to the Pacific regimen of platinum doublet with concurrent radiation therapy and a year of adjuvant durvalumab, and the randomization is with or without a concurrent phase of Q2-week durvalumab at a dose of 750 milligrams. So this trial just opened in the spring, and I know a lot of studies a lot of centers are going through the process of opening this, including ours at Loyola in Chicago. The total randomization, or the total accrual, is about 660 patients with a primary endpoint of overall survival. So we're very excited about this follow-up study.
Thanks, Matt. And so again, for those in the audience who don't know, when another group has a study and we have a SWOG champion, we want to enroll to this trial and give SWOG credit for it. That helps earn us credit with the NCI and the authorship for our young investigators. This is a great study. There's really very few competing studies in the stage 3 arena at this point. So next slide. So the LUO2. So this is an NRG study. I don't see Dr. Gomez on the panelist. So Dan, you can jump in if you want to, but this is an NRG study in oligometastatic non-small cell lung carcinoma. Patients receive 4 cycles of first-line systemic therapy, including chemoimmunotherapy, and then undergo restaging studies. Those that have a limited number of sites of discrete disease are randomized to either continue maintenance systemic therapy or receive stereotactic body radiation to all of those metastatic sites and maintenance systemic therapy. So this is a trial that initially accrued very slowly, but as this concept has gained acceptance, the accrual has increased nationally. Again, we only have one SWOG credited accrual for this, so I would encourage you all to consider this trial for your centers. Next slide. The LU05, Dr. Charles, I think you're on here somewhere, right?
Yeah, thank you, Roy. Thank you so much. So I'm Charles Hsu from University of Arizona, one of the radiation oncologists, and again, a SWOG champion for LU05. Again, this is phase 2/3 trial looking at limited stage small cell lung cancer. So essentially, we're stratifying by both daily as well as BID radiation treatment for limited stage small cell. And then the randomization is to basically standard of care with or without atezolizumab. And atezolizumab basically would start with cycle 2. And similarly, radiation therapy would also start with cycle 2. So accrual is going fairly well. Again, just like Roy was saying, if possible, please try to enroll via SWOG. Again, we only have one SWOG patient on this thus far. In addition, there's a couple proposed amendments that are going through. One is they're going to allow for imaging to be 60 days prior to registration, as well as relaxing GFR requirements to 30. And then the tissue requirements are also going to be relaxed too, which will hopefully help with further accrual. So, thank you.
Thanks very much, Charles. Next slide. The LU007, Dr. Park, I believe you're on.
Yes, so this is the Raptor trial, LU007, just activated last month. This is for extensive stage small cell lung cancer for patients who have stable disease or partial response after 4 to 6 cycles of chemotherapy. Now that the Empower 133 the trial has come out, it's not clear if the CREST the CREST regimen of 30 Gray and 10 fractions for consolidative thoracic radiation still applies in terms of having a survival benefit still in that scenario. So now after chemo and immunotherapy, the idea is to randomize to either getting atezolizumab as maintenance or getting it with low-dose radiation therapy. And it's not limited just to the thorax. It could be also to the liver or other organs as well. So it could be up to 5 sites. And this is also stratified by the number of sites as well, and by whether, and then the other question they're looking at is whether complete consolidation, meaning treating all sites of original disease, versus incomplete consolidation with treating just some, if that makes any difference at all either. So, the goals here, we're really hoping to get some SWOG credit for this. They haven't accrued anyone yet on this study, but it just opened a month ago. So we're hoping to get some patients on this as well. I think this answers an important question about whether or not consolidative radiation matters in this setting.
Thanks very much, Henry. I think in the interest of time, I will pass it back along to Karen unless there are any questions.
Thanks, Roy. So I think you can see we've got a lot going on in our radiation oncology space as well. So I'm going to pass this on now to, to Phil to give us the translational medicine update.
Okay, thank you very much, Karen. So on behalf of the Translational Medicine Committee, I'd like to just present a little smidgen of some of our plasma data that we've been collecting. Specifically on the 1403 and the lung map biopsies that was mentioned before as part of the abstract submission. But I do want to take a moment to reiterate what Dr. Kelly was saying during her introduction, which is that we do recognize that it's difficult to acquire these specimens. It's time consuming, it's an arduous process, and we really are very grateful that you are doing this. It's very important, I think, both to our scientific, but also to our clinical mission. And I want to emphasize that these aren't just sort of abstract scientific endeavors that we're doing right now, but these are actually really important to our clinical mission. And we can translate some of these findings in real time And I hope you agree that they're very important. And just to initiate that, let's talk about the 1403 trial. It's down here in a blue box if you want to remember the trial, but suffice it to say, this is patients that are newly diagnosed with an EGFR mutation, and they're all receiving an EGFR inhibitor, afatinib. The plasma specimens was collected at 3 time points. And again, it's very important, and we thank you for contributing all 3 time points, baseline, end of cycle 2, so about 2 months, and the end of treatment. All of that is very important to our ability to analyze. And we have at this point good follow-up time on this. We do have all the specimens from the first 2 time points analyzed and many of the end of treatment, although there's a few out there that still require collection. There's a couple of patients actually still on trial, I believe. So what you're looking at right now is the dynamic change in EGFR mutant allele frequency. And so just to orient you, there's the 3 time points along the bottom, the start of therapy, the end of cycle 2, and at progression. And what you're looking at graphed is EGFR mutant allele frequencies. And you can see that some of those are actually quite high if you look at the baseline. And just the overall architecture of what's happening here is that the patients are treated, their EGFR mutant allele frequencies tend to decrease, and then they go back up again. And I guess I don't have control, but if you could advance once. Or do I have control? So at baseline, of all these ones where we had collection at all 3 time points, not all of them were detectable. The graphic is actually showing just those cases where we had a detectable level of EGFR. And that was about 77% of them were detectable. And depending on how we do the analysis, go back. If you can pass me control, that would be great. Progression-free survival was significantly shorter for patients with EGFR positivity. So there is a prognostic value to whether these patients are positive or not at baseline. And you can see that some of these patients have really elevated mutant allele frequencies. Up there in the 50s, 60s, there's even one in the 80s, which we don't normally see baseline in patients who are just being newly diagnosed. These are, such high mutant allele frequencies are normally associated with really late stage small cell or patients who are really at end of life. But in this case, next slide, please. The cause of some of those high mutant allele frequencies is the fact that EGFR is often amplified. And using a completely independent analysis for determining copy number, you can see there on the left, those that have high copy number have much higher elevated frequencies compared to those that don't. So basically, these patients have lots and lots of extra copies of the EGFR DNA sequences that harbor the mutations, and that's why they're showing up so high in plasma. And this can be a source of confusion for people who are looking at these things and trying to do, say, for instance, subclonal analysis. It can throw them off. Okay, so next slide. So that accounts for why there are such high levels at baseline. But the key part here, and go ahead and advance it, is that the bulk of these patients drop precipitously after they've started treatment. And so in this case, about 70% of the patients are clearing. What we mean by clearing is that they started out positive at baseline, and they are now decreasing to the point where we cannot detect them at the end of cycle 2. And so what is the clinical significance of that? Next slide. It's actually quite startling. So those that actually clear, so no evidence of circulating tumor DNA at the 8-week time point, have a dramatically improved progression-free survival compared to those who don't clear. You can see the p-value there and the very dramatic hazard ratio of 0.24. But just take a look at the median progression in months. So those who cleared their ctDNA had a median progression-free survival about 15 months compared to about 3 for those that had residual ctDNA. If you go to the next slide, This holds true for overall survival as well. Quite a dramatic difference. 27 months versus 15 months, a strong p-value, hazard ratio of 0.3. So really, in cases where we are seeing this dramatic drop to below detection, those are the ones that are going to have the good positive outcomes. Okay, next slide, please. And so why this is happening is worth looking at individual patients. There are different reasons for why this might be, but you can basically summarize it that there's some level of innate resistance that is preventing the EGFR inhibitor from working as well as it should, and that's what's leaving the residual ctDNA. Now here's a case where it did clear, and you can see it starts at baseline with pretty high EGFR levels, and then at cycle 3, day 1, it's completely gone. It cannot be measured. And then upon a recurrence, we start to see it coming back up again. And in this case, that lighter pea-colored area is an EGFR T790. So this one is progressing with T790 positive disease, and they had a pretty long progression-free survival, and they cleared their ctDNA. Next slide. But here's a case you can see quite clearly that they did not. And this is a very interesting case. I like to bring it up because in this case, we're seeing EGFR T790 emergent, and that's in red, but we actually see it very early at that cycle 3, day 1 time point, which is very unusual. And so this must have had a good burden of T790 to begin with, and it just progressed very rapidly. And this wasn't associated with a short progression-free survival. Next slide. And here's another case you can see it did not clear at all at that first time point. It does decrease a little bit, but then it explodes very rapidly. And what it turns out is happening here, and this was not known when the patient was first put on therapy, I presume, but in addition to an EGFR L858R, which is what was positive for their assignment to this trial, there was also an EGFR exon 20 insertion, and that's the darker blue part there. And basically what happens is that the L858R portion is being controlled. It disappears. You can barely see it even at baseline, but it's gone at cycle 2 and at recurrence. But that exon 20 portion, which is not being controlled by afatinib, is just exploding. And this patient had a very short survival. So basically, again, we can look at these individual patients and have a really good assessment of what is going to happen to them as early as that early time point. Next slide, please. So the combination of dynamic changes in MAFs plus our understanding of these innate and emergent resistance can really help us refine treatment on an individual patient level advance. And there are questions that need to be addressed, and we can address these in SWOG. Early intervention at first sign of emergent resistance, should we be doing that? Switch therapy. Clearance of the primary activating mutation versus companion mutations is very interesting. We're looking into that. The velocity of the changes. There's a lot of information that we can get out of this type of study. Okay, and then next slide. Now, just very briefly, in essentially one slide, I just want to talk about some of the data that was coming out of LungMap in our tissue ctDNA concordance studies. And so here we had 129 patients where we had matched tissue and plasma. And the reason that number is so low is that we only were doing this in patients who are getting a fresh biopsy at the time. Of those 129, 54 of them had recognized driver oncogenes. No ALKs, but lots of EGFRs and KRAS, some RET, MET, and BRAF. And the reason I'm focusing on the oncogenes is that these are mutations that we expect to see basically in all cell lineages, primary tumor and all of its descendant metastatic lesions. And here we found that 80% of these drivers were observed both in the tissue and the plasma, completely matched, exactly the same mutation. It's not too common that we see at the very bottom there in ctDNA only drivers, but we don't know the disposition of these patients and their resistance status. We did observe 2 that were found only in plasma, a MET amplification and an exon 20 insertion for EGFR. And there were, as you can see at the top there in the gray, a little less than 17% were not detected in the plasma. They're seen only in the tissue. And we presume that's a sensitivity issue. And from that, we can derive a sensitivity of 83% and 97% specificity for driver mutations, which is very good. So for the most part, plasma is telling us exactly what we're seeing in the tissue. Now, if you've advanced that once, what you're looking at now are non-drivers. So these are your P53s and ATMs and anything else that might be mutant in the tumor. 439 events across all of the cases. And these kind of divide themselves up a little more evenly into thirds. 38% of them were found synonymously in both the tissue and the plasma. But you can see there's a third of them that are only seen in the tissue and a bunch of them that are only seen in the plasma. And if you advance, this Venn diagram is just another way of looking at that, although here we're showing only short variants, so no fusions or amplification events, and this includes the drivers and non-drivers alike. You can see that the bulk of them are actually detected in both. There are some unique to tissue and some unique to plasma. You could consider these to be false positives and false negatives, things that were missed. But really, there's a lot of biology behind here. In the tissue-only ones, that might be a matter of sensitivity. They're just not shedding, which, as I mentioned, is actually an interesting prognostic factor. But in the plasma, that 116 that you're only seeing in the plasma, those are things that may well be unique to metastatic lesions, to resistance areas, to areas of the tumor that are advancing. So you can pick up a lot of information. And I discourage people from thinking of these as just sort of a miss. I'd like people to focus on the actual biology that might be behind why you see something only in plasma that was not available in that single tiny little tissue biopsy. And with that, if you advance it to the last slide, just by way of conclusion. So we continue to include plasma analysis in a lot of our trials. And again, we recognize that this is a difficult chore. It is a burden on sites, CRCs and nurses and everybody involved in the clinical team. But I hope you'll agree that this is very much worth it, that we are actually really getting cutting edge information out of these things that allow us to advance clinical concepts, not just in diagnosis, but actually how we will go about treating patients. We do have a lot of other things that are coming down the pike in the lung map, but we'll reserve some of the other information that's coming out of the lung map tissue analysis for another time, maybe next time. And we are working finally, if you advance it once, on the 1507 mutation analysis. This is finally just about underway. And I do have to emphasize, like, I'm very sorry how long this takes. I mean, the science hasn't changed in concept from over the last 7 years, really, when it was first presented. We've had a lot of bureaucratic hurdles that have required surmounting, but these are finally underway. And with that, I'll turn it back over to you, Karen.
Thank you, Phil. That was fantastic, and I do think it shows the importance of these samples and that we're really using them for both the clinical perspective as well as the biology perspective. There was one question here from Dr. Karim about, are there specific mutations that tend to be detected more in plasma? She's stating that she's been seeing a little bit more EGFR exon 20 in the plasma.
Yeah, well, as a general category, what you see in plasma, and this is actually more important in certain other types of cancers, like bladder particularly, is you're seeing the metastatic variants, which in bladder and other tissue cancer types are very unique. They're very different from what you actually biopsy in the primary. And that does hold true in lung cancer as well. But what you'll also actually catch are potential resistance mechanisms. And I think we have to recognize, and it'd be great if you could share some of your cases, we can discuss it, that exon 20 insertions may actually be an emergent resistance mechanism in lung cancer for drugs that don't tackle it. It looks like Roy has a question as well.
Yes, he does. Right?
That was outstanding, Phil. Wow, great job. Are you familiar with the effort the Friends of Cancer Research did on harmonization of ctDNA? They actually worked with a statistical group at CRAB and a number of companies, and using these data to look at response and the types of things you're looking at here. I wonder if there might be some opportunities for collaboration there, and just something to think about.
Oh, I hope so. Now, a lot of that harmonization is focused where it's really needed, which is on tumor mutation burden being measured out of plasma, which is very difficult to coordinate and is all over the place and really requires harmonization. But there are other aspects of this type of analysis that could be harmonized, including like that early time points. There's a lot of discussion if we should be even earlier than the 8 months that we're looking at. So there's a lot that could be done. And I'm a big fan of that early time point, in part because of this data, but it's very predictive of whether these patients are going to respond well or not. And in many cases, in this study, there were a couple of patients that had MET amplification at baseline. We could, there's simple solutions to get them back on track and have a good response, and use plasma clearance as a way of gauging that. There's a lot we can do in this space, and so we'd be happy to collaborate with anybody to move that forward.
Yeah, I think David has one last question for us.
Yeah, and it's really more a comment. Some of our attendees may not be aware that the Foundation liquid biopsy assay was FDA approved about 3 weeks ago. So we've been using that assay in its earlier version. The new version will be converted for lung map. So we're moving in the prime time for these assays. We're having a workshop, ISLC virtual workshop on October 2 and 3, which is going to address several of these questions, and Phil is on the faculty.
All right, that, as I said, that was great, Phil. Thank you so much. So we have about 3 minutes left in our break, but I do think we should take at least a 5-minute break here, if that's okay with everybody. And I think let's come back at about 12:05 and we'll start back again. Excited to hear Janet's perspective. She's always a very inspirational speaker, and looking forward to that. So let's come back at 12:05 and start again. Hello?
Hello?
Karen, it's Judy. Hi, Roy.
We back in the panel?
Karen, your screen is black. Or your little camera thing's black. There you go. Karen, I'll just take a minute before I introduce Janet for a couple quick updates, okay?
Yes, I was planning on that, Judy. Thank you for the reminder.
Are we in closed session?
I don't think so.
We're right back on time?
It's now, of course, my time, it's 10:05, but wherever you are, according to the agenda, it should be about 12:05, and we are going to go ahead and get started again for the last session here of our lung committee meeting here. So I'm going to introduce Judy Johnson. She is our patient advocate, and she has some announcements for us, and then she'll introduce the next speaker.
Thank you, Karen. Hi, everybody. I wanted to just give you a couple of quick updates before our introduction. So in our patient advocate virtual meeting Wednesday, Dr. Blanke and Dr. Eng talked with us about the SWOG Post-COVID Innovation Task Force. And afterwards, we looked at the 7 major COVID trial allowances made by NCI, as discussed recently on the COVID Lung Cancer Consortium call. The top 4 that we ranked were localizing study activities, shipping the oral agents to patients, using telemedicine, providing an option for remote informed consent. And for all of them, we agree that it's critical to be aware of and address the patient's needs as these initiatives evolve and move forward. Then yesterday, interestingly, during the OISHI symposium, the panelists on that phone call from various organizations ranked these very, very similarly, with telehealth as number 1, remote informed consent number 2, shipping the oral agents number 3, and localizing study treatment is number 4. In fact, one of the panelists said that they offer curbside pickup of study drug, which I thought was extremely creative and very focused on patient needs. It'll be important to plan for and build these adaptations into our new concepts and protocols. So now I'm very happy to introduce Janet Daly. Janet is a retired aerospace systems engineer, freelance writer, speaker, and metastatic lung cancer patient advocate. I met Janet in 2018 at the IASLC targeted therapy meeting, and then again at a lung cancer SPORE workshop. She's one of the most energetic, passionate, and effective patient advocates I have ever met. After hearing her talk at the WCLC 2020 Virtual Presidential Forum, I knew that what she had to say would be really important for all of you to hear. Her comments about the reality of clinical trials and the barriers that patients face to participate are eye-opening. We all need to be aware of and address barriers as we develop trials to maximize patient impact. Janet, thank you so much for being a part of our lung committee meeting today.
Thanks for the introduction, Judy, and thanks to SWOG for inviting me to speak. I'm going to give you a snapshot into a lung cancer patient's manifesto for modernizing clinical trials. I can't address in 10 minutes all of the aspects of clinical trials that could use modernizing. Instead, I'm going to focus on a few issues that have become prominent in light of recent events. Next slide. I have nothing relevant to disclose. Next slide. I'm alive because of clinical trials. My lung cancer progressed to stage 4 despite 2 different lines of curative chemo and radiation. Thanks to biomarker testing and a targeted therapy clinical trial, I have had a relatively normal life 9 years after diagnosis. Most patients know clinical trials are not guaranteed to provide effective treatment. However, in this era of rapidly evolving lung cancer treatments, a clinical trial might be a patient's best treatment option. For patients, clinical trials are treatment. Clinical trials are hope. Everyone interested in participating should be able to access a clinical trial appropriate for their cancer. Approximately 75% of people surveyed globally were willing to participate in a clinical trial. And yet, next slide. A study published last year found only 8% of adult U.S. cancer patients participated in NCI or industry clinical trials. The COVID-19 pandemic highlighted a stark reality. We have significant disparities between the population of clinical trial participants and the population of people who actually have a disease. And we haven't made a lot of progress dealing with disparities over the past several decades. As a research advocate, a cancer patient, and a person interested in justice, I want to see such disparities eliminated. The first step in eliminating a problem is knowing it exists. What do disparities in clinical trials look like? Next slide. One form of disparity is based on ethnicity. A 2019 study found Black and Hispanic lung cancer patients were consistently underrepresented in pivotal FDA approval studies compared to populations of other people who had lung cancer. As you can see, Asians tend to be overrepresented in trials compared to the disease population, whereas Black and Hispanics are underrepresented. Preliminary reports indicate Blacks and Hispanics are underrepresented in COVID-19 trials also, despite being disproportionately afflicted by severe cases of the disease. Next slide. Disparities exist with regard to age and income as well. A 2019 study found the average age of a lung cancer trial participant was around 61 years, whereas the average or the median age of diagnosis is 9 years older than that. Age disparities tend to be increasing with time. A 2016 study found cancer patients with annual household income below $50,000 had 32% lower odds of trial participation than higher income patients. The disparity was even greater in lung cancer. 93% of the respondents in this study were white, suggesting that income alone can be a huge determinant of trial participation. Next slide. Many systemic barriers limit clinical trial participation in these communities. One barrier is the healthcare system itself. Does the patient believe the trial will benefit them or their community? Do eligibility requirements reflect the typical patient population? Another barrier is economic support. Does insurance cover care at the trial site without prohibitive out-of-pocket expenses? Can the patient get time away from work or cover family obligations? Do patients have the means to travel to the trial site? And travel is not just about flying to a trial site in another state. It could be a lack of a bus route. Yet another barrier is technology access. Does the patient have access and skills for remote consent to telemedicine? Next slide. So what can be done about these disparities? There are 3 approaches to dealing with disparities in access: equality, equity, and justice. To illustrate these concepts, imagine 3 people of different heights want to watch a soccer game, but there's a fence between them and the game that blocks their view. Equality gives everyone the same size box to stand on. This may enable the taller people to see the game, but the smallest person still can't see. Equity personalizes supports for each person. It gives each a box that's high enough to allow a clearer view of the game. This is affirmative action. Everyone gets the support they need. Justice removes the barrier itself. All 3 can now see the game without supports or accommodations because the cause of the inequity was addressed. The systemic barrier has been removed. We need to incorporate these concepts into clinical trial design to eliminate disparities. Next slide. Clinical research is guided by the 4 pillars of medical ethics. I've highlighted 2 of them. Beneficence, which suggests that doing what's best for the patient should also consider the patient's wishes, and justice, which suggests that all patients should be treated equally and resources should be allocated fairly. How do disparities in clinical trial accrual violate the ethical pillars of beneficence and justice? They deny access to clinical trials for some who might wish to participate, and they put patients who do participate at risk without ensuring the trial will complete accrual and be able to provide useful information. It's been 17 years since the Institute of Medicine published their Unequal Treatment Report, which demonstrated that U.S. racial and ethnic minorities often receive lower quality health care. Not much progress has been made since then, but we can take steps to reduce disparities and increase access. Next slide. Collaborating from the beginning with community advocates can have a dramatic effect on accrual and trust. One terrific example of this is the Metastatic Breast Cancer Project, which involved metastatic patient advocates in all aspects from the very beginning. This graph shows the project's initial accrual, which increased dramatically when knowledgeable and respected advocates blogged or posted about the project. Because of this partnership with community advocates, the project enrolled over 5,800 U.S. participants in less than 2 years. Next slide. Incorporating modernized eligibility criteria can also help with accrual. Most traditional criteria were developed in the era of cytotoxic chemotherapy and have been a major barrier to patient enrollment. In July 2020, the U.S. FDA released several guidance documents to modernize clinical trial eligibility criteria. Next slide. In 2019, a retrospective study examined 10,500 records of patients with lung adenocarcinoma in community hospitals. It found 47.7% of patients were ineligible for clinical trials by 3 traditional exclusion criteria: no brain metastases, standard kidney function measures, and no other cancers. However, when the modernized eligibility criteria suggested by ASCO and the FDA was applied to the cohort, only 1.5% of patients were ineligible. That's over 4,800 more lung cancer patients available to participate in clinical trials. Next slide. Once a treatment is approved, patients will want to know if the survival benefit is worth the side effects they may experience. In addition to creating tools that capture the patient experience, we need to capture how the experience varies based on characteristics such as age, comorbid conditions, and ethnicity. This will give patients better ways to assess which treatment is the best for them, given their needs, values, and preferences. Next slide. Greensboro Health Disparities Collaborative partnered with 2 cancer centers to test whether customized supports could improve the experience of Blacks undergoing treatment for early-stage breast and lung cancer. Specially trained nurse navigators worked with patients to ensure they understood their treatment options and had financial and social supports. Before the study, Blacks were less likely to complete treatment than whites. After the study, treatment completion rates increased among all patients, but they increased more in the intervention group, and more Blacks than whites completed treatment. Personalized supports provided equity. Next slide. Given the cost and inconvenience of travel to clinical trial sites can be a major barrier for participation, technologies such as telemedicine can help eliminate disparities. During the COVID-19 pandemic, several countries enabled broader access to telemedicine. While this has allowed more patients to see their clinical trial doctor through remote visits, we must be careful to ensure that this technology does not increase disparities. Not all patients can afford or manage broadband internet, devices, and software required to enable telemedicine. Next slide. To summarize, some ways to address clinical trial accrual disparities and increase access are to rethink justice and beneficence, build trust within the community by collaborating with community advocates, modernizing eligibility requirements, and designing patient-reported outcomes to capture the patient experience, provide customized supports that address the patient's needs, and provide tech access and training for remote participation. I hope this gives you some ideas for reducing disparities and increasing access to clinical trials. Thank you for listening.
Thank you, Janet. That was outstanding. Do we have any questions for Janet here? Janet, can I just ask you, what are your real thoughts about how to move forward here?
Well, there's several efforts developing now to address the issue of disparities. I just saw a presentation out of Harvard that was done jointly with the FDA. And a lot of them are focusing on bringing in community members to find out what the needs are and where the disparities exist and where the barriers are to access so that people can start addressing them. Some programs have been very successful in working with the community to provide supports that are necessary.
And what do you think a community advocate looks like?
There are many different communities, all with different advocates,
right?
And they're reached by different means. I mean, there are now many more research advocates among the lung cancer patients, but the majority of us are white women, older, because we're the ones that had the resources and the time available to be able to do this. We need to reach other communities as well.
Yeah.
In on that one, Karen, real quick, because we do have 7 community advocates that address various communities, such as African American, Asian Pacific, older adults, adolescents and young adults, military veterans, and there's a couple more that I'm not thinking of off the top of my head, but that would fit in really well with what you said, Janet.
Well, I think they would be gems. It's really how do we actually find more of them? I think you're right. SWOG's doing a great job in that arena, but it's really about finding more and finding local ones to help local communities as well. But Janet, again, thank you so much.
You're welcome. Dr. Gandera had something to ask.
Oh. David?
I have a question too.
Okay.
Janet, that was wonderful. Do we have enough diversity in our workforce, in our physicians and our fellows and our nurses? And if not, how should we promote that and increase training to make it better?
The statistics indicate that no, we don't have a lot of diversity in the workforce, certainly not one that's representative of the patient population that's being served. And I think that in some ways, those supports need to start in terms of encouraging people to go into medicine and providing the supports they need to be able to be successful.
Yeah. Go ahead, Roy.
No, I guess I would agree with you, and I think this is something SWOG can do, and maybe the lung committee could do to try to reach out to bring more people of underrepresented groups into this field.
Sorry, I was on mute earlier. My question, Janet, is about your feelings on social media for patients and for patient advocates and advocacy groups. I was in a virtual advisory board last night where the entire topic was digital medicine and especially social media. On Twitter, for example, the lung cancer community, and I mean patients as well as oncologists are very active. So what are your thoughts, or do you think there are pros and cons, or what do you think about this topic?
Well, as you may know, I was one of the co-founders of Lung Cancer Social Media on Twitter, so I've been watching that community evolve. And I was one of the, I participated in Inspire and have been involved in watching the Facebook groups growing on social media. There's now 10 separate Facebook groups for patients with biomarkers of some sort, and also those who are on immunotherapies. And as long as you have a strong moderator that is willing to make sure they only evidence-based information comes into the group, they can be incredibly useful for patients who want to talk to other people who've got the same cancer they do and are undergoing the same treatment. But honestly, if you look at the population of people in that group, they tend to skew white, wealthier people. We don't have a lot of diversity in those groups either.
Okay, thanks for your comments.
Yeah, I think there are a lot of opportunities here, and I think that this is going to be a growing field. Again, thank you, Janet, so much. Appreciate it.
Thanks for inviting me.
We'll now move on to the last session, and that is the medical oncology session here. So we're going to look at the current trials that we have activated, and first on the list is Insignia. And is Dr. Chang on?
I'm in touch with her, Karen. She's having trouble dialing in, so maybe we can skip this and come back to it in a second.
Sure. She has some polling. I believe we have some polling questions here for her. So yes, we can.
I know she's been texting me trying to figure it out, so she's working hard on it.
Okay. We appreciate that. I'm sure she'll get connected here in just a second. So if we could go then to the next skip the next two slides as well, and we'll go back to them. So Roy, then you're up on LIMAP, the screening trial.
Okay. So the screening trial is going well. I'm happy to report that even with COVID, we maintained accrual. You know, as is the case, some sites were up when others were down and so forth, but we've maintained a steady accrual. Of course, we're doing LungMap now, so the open trials are in green. The last accrual number, I'm looking at it now, total registrations, need my glasses, I think it's 1598 as of September 25th. So we're doing really, really well. You can see we have 3 arms open, the rucaparib, talazoparib plus avelumab, and LAXO-292. You know, so, you know, all, you know, the LAXO-292 is approved now. This is in the second line setting in that trial. Remember, we take patients with outside test results. They can start, but it needs to be confirmed. And then going very well is the trial of pembrolizumab ramucirumab versus standard of care. In fact, it's accruing very fast, and we have several new arms, sub-studies in the works. I believe we're going to talk in more detail about sub-studies in a moment, so I won't go through that now. But I want to thank everyone for their work. I want to thank the Statistical Center and the Operations Center. We get a lot of queries and calls, and we try to answer them. And you know, the key here is now to bring a few new things forward. And this is, of course, being run through the intergroup mechanism. So we have a structure that includes all the cooperative groups, and we have trials coming in from many different places. So it's just been a very positive experience, and I thank everyone for their support of the study.
Thank you, Roy. So Anne is now on. So if we could go back to 3 slides. And yep, go back to the skip. There you go.
Oh, sorry, I forgot my video. Here, I'm still here.
Thanks. Sorry that I'm late. Had some connection. But I wanted to talk about Insignia, which many of you have heard about before, and give you an update. We have almost 200 patients who are who've accrued, so we're about a quarter of the way through, a little bit less. I will say that SWOG needs to increase our participation because we're on the lower side. We have about 25 of those, and the rest are ECOG or Alliance. So I'm hoping that you will remember to think about this for your patients. It's a frontline trial for non-squames who are PD-L1 positive, at least 1%. And the arms are Pembro alone, followed by carbo-pem upon progression. Arm B is pembro alone, and then adding chemo to the pembro upon progression, and Arm C is our standard combination chemo and immunotherapy. I do think that, anecdotally, I have a number of patients who, we had talked about this at length previously, whether or not we would feel comfortable putting patients on who had low PD-L1. And I've had a couple of patients who've done extremely well with low PD-L1. So that's anecdotally, but I do think it's a really important question. Number one, can we spare the chemo in the front line? Number two, what happens if we add chemo to immunotherapy in Arm B? And of course, the translational aspect of it, which is that we're collecting tissue so that we can really look at what that signature is for predictive signature for chemo added to immunotherapy, and prognostic signature for pembro alone. We do have about half and half right now that are greater than 50% and lower than 50%. So I think we're going to be able to weigh in and get some really interesting data on these questions. So we'll stop there. I don't know, Karen, we had a polling slide, right?
Yes, yes. You have two.
So thank you. We really wanted to understand the barriers to enrolling patients in Insignia for SWOG. So the choices are, number one, the continuing COVID pandemic, certainly a good reason. Number two, the trial is too complex. Number three, concern about enrolling patients with 1 to 49% TPS score for PD-L1. Number four, all of the above. Or number five, there are no barriers and we are accruing. So that we really hope to understand the barriers. And Karen, does the answer come up right away?
It's going to take 30 seconds. You can see it on the side of your screen, and I know you just joined, but you should be able to see the polling. It should be counting down here, although mine seems to be stuck at 18 seconds. But and then the results will come up. It does take a minute. Oh, here we go.
Can you vote once, or can you do mail-in ballots?
You can vote only once.
Okay, yeah, we have the answers here, and it really actually, there are a few people who are concerned around enrolling the PD-L1 1 to 49, just a few people, that's 6. And 8 people who answered there are no barriers, 3 who said the COVID pandemic, and 1 who said it's too complicated, but lots of people that are not answering. So
no, you need to use your vote. That's a big deal these days.
Yes.
Right, that's exactly right. Well,
you've got to put my mask on, see?
Okay. Yeah, we do want to encourage people to vote. Maybe they're not actually connected to the web, or I'm not sure what that is, but yes, please vote. Or maybe they don't feel comfortable voting, but nonetheless, let's go to the next question. Oh, okay. Well, this one might be irrelevant here, but I was asking for the number 1 barrier.
Okay, well, this is your chance to vote again. What is the number 1 barrier for you in enrolling patients in Insignia and understanding that not everybody is accruing? Number 1, because of COVID. Number 1, the continuing COVID pandemic. Number 2, the trial is too complex. And number 3, the 1 to 49.
Or other.
And 4 is other. And just while we're waiting, a comment by Anna Velasquez, the timing of the NGS panel results and then adding the trial of the time of trial screening procedures may decrease the number of patients who can wait. I will mention, because this we've gotten a lot of questions about, you do not necessarily have to have tissue. So you can use archived tissue. And so even though we are really trying to get tissue, you don't have to have the 20 cores that so there is some leniency there. And if you have any questions about patients, feel free to email me or Haas, and we can certainly help you through it. And so the answers are back, and it looks like 11 folks said other, 8 said the third choice 1 to 49 PD-L1, 3 said the continuing COVID, and again, most folks not able to answer or no answer. I hope we do better at November 3rd or November.
Yes, we will. First, all right. Well, we appreciate those who did answer. Okay. All righty. Now let's go to, we were on lung map, and now we're going to go to the lung map sub studies. So Dr. Reese, go to the slide before. Yes, Dr. Reese, 1900A. Did you want to make a little comment, Dr. Reese? Did we lose Dr. Reese? Well, I think the slide is self-explanatory. This trial has met its accrual for the interim analysis, and both cohorts are closed for interim analysis, and we're just waiting patiently for the interim analysis. So nothing more to say about that, but great that we have met the accrual goals here. So we'll move to the next slide. Yeah. And I don't know whether, so this is 1900B. Roy, you were starting to talk about that, and I think that Jhanelle and Yasser may not be on, so you can continue your talk about this particular trial, which is our LOXO study.
Right. Well, I don't know if anyone's ever treated with the RET inhibitors, but they really work pretty well. So you want to find these patients. So RET fusion positive stage 4 recurrent lung cancer, prior chemotherapy is required. Prior immunotherapy is allowed, and it's the LOXO drug. And I'll be honest with you, the accrual to this has been somewhat slow. I'm not sure why. This should be about, what, 4 or 5% of the patients with lung cancer. We are beginning to, maybe there's a bit of a lag from the screening. We do allow any FMI tissue-based assay, other tumor-based CLIA assay, ctDNA, and FISH. So we're letting people come on with outside tests, which we then confirm through our current platform. We have a little group that reviews this. The translational committee, pathology group reviews these quickly to make sure that they're acceptable. But keep this in mind. This is the way, again, many of us will probably be using this in the front line, which is a problem. And, but in the second line, if someone hasn't had the RET, and we find these patients, this should be a very good study, and it should get RET inhibitors to all parts of the country, which is important too, with testing.
Thank you, Brian. All right, next. All right, so the next one is 1900C, and I know Marie, Dr. Suga is on to discuss this trial.
Yes, can you hear me?
Yes.
Okay, great. Yeah, so this is S1900C. So this is a phase 2 study of talazoparib plus avelumab in patients with STK11 stage 4 non-squamous non-small cell lung cancer. As you can see, here's the schema of the trial. Very straightforward study. Essentially, if STK11 is found by Foundation 1 assay, assigned to the SWOGs. In general, I think the enrollment is going very well on this particular trial. We activated on January 16th, and we have planned accrual of 44 patients. Thus far, we have 28 enrolled, so we're very excited about that. And we do have a planned hold of this trial after 20 evaluable patients have been reached, and I'm told that's probably in a couple of months. So thank you so much for the support of this trial. We really do appreciate the accrual, even with the COVID pandemic, we're really accruing very well to this trial. So very pleased. Thank you.
Next slide here. Okay. Dr. Retkamp.
So yeah, we have accrued incredibly well to this trial, and we're not slowed down significantly by COVID. We actually have met our N as of today is 144, although we had some initial issues with eligibility, and so we expect this number to go up to 150, 155 or so. And so we expect a month or two more of accrual, and this will likely close within the next 30 to 60 days.
All right, thanks so much.
Hi, Karen. It's Jonathan Reese. Sorry, I got called away for a patient issue for a sec. Thanks for discussing SWOG 1900A. We're eagerly awaiting the interim analysis.
Yes. Thank you, Jonathan. You know, Marie, I think your slides got in a different section. I apologize. I think they're also in another section. I know you had more slides there. I apologize.
No problem. No problem.
Okay. Next slide. All right, Roy, do you want to discuss this chart as a segue into Dr. Gadgil's presentation?
Right. So this slide sort of says it all. It's a nice slide, but basically this is the KRAS, the Amgen 510 that Karen mentioned at the beginning of the meeting today, presented last week, and the drug looks pretty good. About a 30% response rate in all comers, with got over that sort of 6-month median PFS that we all look for. But could it work better in certain subgroups? Of course, at some point it's going to be combined, and hopefully we'll do trials like that too. But here's a trial where we screen the patients, and because we're getting the full sequencing on all patients, we can look at different subgroups. So we can look at cohort 1, patients who have the KRAS G12C. It only works in G12C, 13%, but they also have to have a TP53 co-mutation, P53. So that's cohort 1. Then there's cohort 2, the infamous STK11, and if you have co-mutations there, patients will go in that arm. And again, this is really the essence of LungMap, finding these patients because of the screening. And then cohort 3 will take everyone else. And remember, in that group, you might end up having double mutants and many different things. So everyone will go on who has G12C. And this we're rapidly putting this through. Everyone's firing on all cylinders to get this open as soon as possible. But Suki and David are working on this. Suki's at Stanford, David's at UT Southwestern, and they've been very engaged. And of course, Mary Redmond's been doing an amazing job as always. So yeah, this is moving along very well.
Thanks, Roy. All right. Hopefully it'll be open by the end of the year, correct?
We hope so. Before the vaccine, we want this trial open.
All right. All right, next slide. Let's see what we have here on the next slide. Okie doke. Okay, so we also wanted to talk to you about another concept that has been approved by the Drug Selection Committee, and it is working its way, that we're very excited about for the non-matched arm. And we have Dr. Rangel, who has been working with this agent, and he's going to tell you all about it. This is a very exciting study. Dr. Rangel.
Thank you very much. This is my first time presenting about the LungMap group, so I apologize for not following the format of the previous presenters. If you could give me the next slide, please. The concept involves a IL-15 based reagent, which is a member of the common gamma chain agonist family of cytokines. More familiar member of this family is IL-2 and has been approved by the FDA for administration in a high dose format and a highly toxic format requiring specialized centers. Next slide. Next slide again. There was an animation there. If we can just, get past the animations. N803 is this IL-15 based reagent. It has a few modifications that are intended to increase its activity over native recombinant IL-15 by about 100-fold. It strongly activates CD8s and natural killer cells, and because it doesn't interact with CD25, like all IL-15 molecules, it spares expansion of the CD4 compartment. Next slide. So I ran an investigator-initiated trial, phase 1B, with a phase 2 expansion. We published the phase 1B result in Lancet Oncology, showing that N803, this highly active IL-15 reagent in the family of IL-2, is safe to be administered in the outpatient setting in combination with PD-1 therapy, in this case nivolumab, and saw early evidence of activity. Next slide. This is just some of the safety data. Most of the experience is injection site reactions and flu-like symptoms. We actually may see a decrease in immune-mediated adverse events with the therapy, which we don't have time to talk about here, but seems to be a stable observation. Next slide. This is a patient who progressed on single-agent nivolumab after experiencing a response, and experienced another response after the addition of 803, then named ALT803, to uninterrupted administration of nivolumab. Next slide. This is a patient who had a response to pembrolizumab and pemetrexed, had about a 40% response that didn't last terribly long. At the time of RECIST progression, the patient had the chemotherapy, the ongoing pemetrexed dropped, and N803 was started, and has had a greater than 70% response for over 2 years, and is now on surveillance off therapy. Next slide. Patients who have had a prior stable disease or PR or CR to immunotherapy-based regimen seem to do better in terms of progression-free survival than folks who were refractory to immune-based therapy, and that's denoted in the blue bar is relapsed patients, and the red bar is refractory patients. So prior response to immunotherapy-containing regimen seems to predict response to PD-1 plus this IL-15 based reagent. Next slide. This is best RECIST response amongst refractory to PD-1 checkpoint inhibitor patients and relapsed to PD-1 checkpoint inhibitors. Relapsed is defined as stable disease or PR or CR. Refractory is best response is progressive disease. And even amongst folks with progressive disease as best response, we get stable disease and target lesion shrinkage, but you can clearly see that we can get folks back into PRs fairly predictably, and a high clinical benefit rate. Next slide, please. This is the swimmer plot. There are many patients with ongoing responses, including off of treatment. You'll notice that the ongoing patients here are past 24 months. And even amongst the refractory population, I had a patient with stable disease for approximately 24 months, but several with over a year of stable disease. Next slide, please. So N803 in combination with PD-1 checkpoint inhibitor is very safe. We've now combined it not only with nivolumab, but multiple other PD-1 drugs. We're able to get relapsed patients back into stable disease and even response, and even observe clinical benefit, as suggested by long-term stable disease amongst PD-1 refractory patients. And we're very excited to bring this to LungMap and to look at this combination as compared to a standard of care arm in a randomized fashion in the very near future. Next slide. Obviously, a lot of folks to thank, but we won't go through that. Thank you very much.
Thank you, John. That was really exciting presentation, and I think we are very, very enthused about looking forward to getting this non-matched arm open as soon as possible. So hopefully it will be, sometime in the late spring, early summer of 2021. So we wanted to share that.
Hey, Karen?
Yes, Roy?
Hey, Jen, that was a great talk, and we're excited to have you and your colleagues involved. Quick question. Katie Paletti asked me a question. And, on our lung spore, we've shown that some patients with lung cancer lose MHC or beta-2 microglobulin. Potentially, could this therapy overcome that?
Well, my lab colleague and I are submitting an R01 on that very topic. I think one of the really important things about participation in LungMap is the focus on biomarkers and rebiopsy. And I think that right now I currently don't have the biospecimens that allow me to answer that question. And so I'm really looking forward to emphasizing rebiopsy for this trial.
Yeah, some of those samples might already exist. Fred, Phil, that we could even mine from some of the patients that have gone on. We have 1,600 patients.
But apropos of Dr. Polides' comment, yeah, loss of MHC, even selective loss of MHC, not even broad loss of the entire MHC class 1 repertoire may predict PD-1 failure. Whether and how that makes a patient eligible to response to IL-15 and potential immune surveillance with natural killer cells, which obviously are canonically directed to attack MHC class 1 deficient tumors, that remains to be seen.
Thanks. We'll discuss this more. We're hopefully the first of many trials like this. Good.
Yes. All right. All right. Thanks again, Dr. Rankel. So we're going to move now to our last scientific presentation of the session. And of course, Dr. Shirish Gadgil does not need an introduction. He is a well-experienced SWOG investigator, and he ran S1507, the docetaxel plus trametinib in the KRAS patient population. And with all the excitement around KRAS agents, we'd asked him to give a short scientific presentation on emerging concepts for the management of KRAS mutation positive non-small cell lung cancer. Thanks, Shirish.
Thank you, Karen. These are my disclosures. So as is well recognized that over the last few years, the major advance in management of particularly metastatic non-small cell lung cancer is the recognition of driver genetic alterations that can be targeted for therapeutic benefit. However, the most common driver genetic alteration is KRAS, which occurs in about 20 to 25%, 25 to 30% of non-small cell lung cancer patients. And until now, at least, we don't have approved targeted therapy for this particular subset. Even though KRAS was recognized as a driver genetic alteration in lung cancer now almost 40 years ago, it has been challenging to develop inhibitors against KRAS for many years. So the focus initially has been on downstream signaling pathways. KRAS can activate several downstream pathways, including PI3 kinase, but the dominant pathway appears to be the MEK-ERK pathway. And so initially, there was a focus on inhibiting MEK as a way of managing KRAS cancers, including KRAS mutant non-small cell lung cancer. As everybody is aware, one of the efforts was the addition of selumetinib, a MEK inhibitor, to docetaxel in recurrent non-small cell lung cancer patient. And as seen on your left, even though the initial results of a randomized phase 2 study were very promising, the subsequent phase 3 study did not show any benefit with the addition of selumetinib in recurrent KRAS mutation positive non-small cell lung cancer. However, the story of MEK inhibitors may be far more complex. One of the dominant effects of MEK inhibition is the inhibition of phospho-ERK. However, when phospho-ERK is downregulated, it in turn increases activation of CRAF, which then binds to MEK and thus causes MEK activation and can blunt the effect of MEK inhibitors. However, there is a differential efficacy of MEK inhibitors in terms of not only inhibiting MEK, but certain MEK inhibitors may inhibit the binding of CRAF to MEK and therefore can blunt the effects of CRAF activation due to the downregulation of phospho-ERK. And this, in at least preclinical models, suggest that MEK inhibitors with this activity of inhibiting CRAF to MEK can have greater activity than MEK inhibitors who are unable to do so. In addition, there is data to suggest that MEK inhibitors may have selective activity or rather greater activity in certain KRAS mutation subsets. As is well known, G12C constitutes approximately 35 to 40% of all KRAS mutant non-small cell lung cancers. And preclinical data suggests that MEK inhibitors such as selumetinib, both given as single agents, but also when given with chemotherapy, appear to have a greater activity in the G12C subset as compared to other subsets. And this is particularly because in G12C subset, there appears to be a greater activation of downstream well as the data that MEK inhibitors with chemotherapy may be more efficacious in KRAS G12C subset. We conducted a phase 2 study, SWOG-1507, that looked at the combination of trametinib plus docetaxel in recurrent KRAS mutation positive non-small cell lung cancer. The goal was to look at the response rate in the overall KRAS mutation subset, but there was also secondary endpoints of looking at efficacy in specific KRAS subsets, particularly G12C and non-G12C. The study showed that the overall response rate was 33% in the KRAS mutation positive cohort, which was not too dissimilar from the initial randomized phase 2 study of selumetinib plus docetaxel. However, when we looked at the efficacy according to G12C versus not G12C, we found that actually the efficacy was somewhat less with the combination in G12C subset as compared to the non-G12C subset, contradictory to the preclinical data. Now, one needs to be mindful that the numbers are very small. The goal of the study was to enroll a minimum of 25 G12C patients. However, at the time of enrollment, some patients were wrongly registered as G12C when they had non-G12C mutation. Nonetheless, I very much doubt that if we had even enrolled 25 patients, that the efficacy in the G12C subset with this combination would have been necessarily better than the non-G12C subset. Now, there's another level of complexity to the efficacy of MEK inhibitors. As was mentioned earlier, KRAS biology and possibly response to therapeutic agents could be defined by presence of co-mutations, including P53 and LKB1. And these co-mutations may define distinct biological subsets within KRAS mutation lung cancers, which may have therapeutic implications. And again, going back to preclinical data, though at least in our study, it didn't pan out, it has been shown that the combination of MEK inhibitor plus chemotherapy may be less efficacious in tumors that are P53 co-mutant, particularly in KRAS G12C tumors that have co-mutations in P53. And based on this data, PhilMac and the translational oncology team is conducting an analysis of tumors of patients enrolled on SWOG-1507 to assess the co-mutations P53, LKB1, and to assess if the efficacy of trametinib plus docetaxel is different based on the presence of these co-mutations. So if I had to briefly summarize the role of MEK inhibitors in KRAS mutation non-small cell lung cancer, that at least preclinical data suggests that the benefits of MEK inhibitors may differ in different subsets of KRAS mutant non-small cell lung cancer based on the specific allele, that is G12C or not, or the presence of co-mutations. And this, I think, does need to be further studied. Of course, there's a great deal of interest with immunotherapy in KRAS mutation positive non-small cell lung cancer. A retrospective analysis of several second-line checkpoint inhibitor trials suggested that the efficacy of checkpoint inhibitors as at least single agents is greater in KRAS mutation positive non-small cell lung cancer as compared to KRAS wild type non-small cell lung cancer. we analyzed retrospectively the results of the data from Keynote 189, which evaluated the addition of pembrolizumab to chemotherapy in non-squamous non-small cell lung cancer. And what this analysis showed is that the combination of chemotherapy, pembrolizumab and chemotherapy provided similar benefit in KRAS mutation positive lung cancer as it did in KRAS wild type non-small cell lung cancer. So unlike the retrospective analysis with single agent, we did not chemotherapy. But in at least this study, there were not sufficient number of patients to truly assess whether presence of co-mutation with LKB1 influences the efficacy of this combination in KRAS mutation positive non-small cell lung cancer patients. Now, as Karen mentioned at the beginning of the session, we truly are entering into a new era of development of drugs targeting the KRAS pathway. We have a much greater understanding of upstream receptor tyrosine kinases, such as EGFR, in the role of KRAS signaling. Molecules such as SOS1 and SHEP2 that are nucleotide exchange factors, as well as many of the downstream molecules that are involved in KRAS signaling, including the understanding that inhibition of downstream molecules such as phospho-ERK can actually in turn lead to upstream activation of receptor tyrosine kinases and can blunt the efficacy of therapeutic agents. Of course, the greatest buzz is regarding direct inhibitors of allele-specific, I apologize if my audio is not great. Clearly, the greatest interest is in these allele-specific RAS inhibitors, AMG 510 and Mirati 849. However, though these are targeting G12C, it's important to note that at least in the preclinical setting, there is a great deal of drugs that are trying to target other allele specific, such as D12D and G13D, and that bind to KRAS and block the inhibition of nucleotide transfers by molecules such as SOS1 and SHEP2. So it is quite possible that we will have direct inhibitors against G12D and G13D and other such allele-specific inhibitors beyond the G12C inhibitors that we have. Sorry, I'm not able to move now. Okay, thank you. I'll now focus on the direct G12C inhibitors. And I believe that these three factors form the basis of the G12C inhibitors. We all know that the mutant KRAS is resistant to GTPase activity and therefore stays in the active form, which leads to the oncogenic phenotype. However, what needs to be recognized is that there is some hydrolysis of these mutant KRAS. So you do have some amount of the inactive form of GDP-RAS. And in fact, among the mutant KRAS, G12C has the highest hydrolysis rate. So it has the greatest proportion of the inactive form present in the tumor as compared to the other mutations. Secondly, cysteine is a highly reactive amino acid and therefore can bind covalently to many molecules. And finally, and most importantly, Shokat and colleagues identified an allosteric binding site behind switch 2 called the so-called the switch 2 pocket, which can be a site where agents can bind. So AMG 510 and MRTX 849, next slide, bind to this switch 2 pocket, when the G12C is in its inactive form in GDP, and by binding covalently to cysteine, lock KRAS in this inactive G12C GDP form, preventing it being activated to G12C GTP. And it's this sort of locking of this inactive form that inhibits the mutant KRAS and thus inhibits downstream signaling and produces the anti-tumor effect. As Karen mentioned, next slide, the data about AMG 510 was presented at ESMO last week. This was a dose escalation study. The randomized phase 2 dose that was determined by this study, next slide, was 960 milligrams. Next slide. These are the baseline characteristics of the patients. You can see many patients have received 4 connection to my DOR was approximately 10.9 months with a progression-free survival of 6.3 months. Next slide. So these are the adverse effects. Next slide. And this is the median duration of response of 10.9 months with a median PFS of 6.3. Includes patients that were treated at a lower dose, though efficacy was seen at a lower dose. Next slide. Similar data has been reported with the AMG 510 slide. And then I want to finish up with the mechanisms of resistance to these drugs. It appears that these direct inhibitors appear to inhibit primarily downstream MEK and are not able to inhibit as much downstream PI3 kinase. But some tumors, next slide, appear to be more dependent on, keep going, a couple more slides. Appear to be more, this one. Some tumors appear to be much more dependent on the PI3 kinase pathway. And so they could have intrinsic resistance. Whereas as far as acquired resistance is concerned, as I mentioned, inhibition of phospho-ERK can lead to upregulation of receptor tyrosine kinases, as well as upregulation of these nucleotide exchange factors, SHEP2 and SOS1. And based on these understandings, there are several trials that are ongoing that are looking at direct G12C inhibitors with EGFR TKIs such as afatinib, SHEP2. There's data to show that inhibition of G12C can create a tumor microenvironment that is conducive to the activity of checkpoint inhibitors, and therefore there are trials combining it with checkpoint inhibitors and as well as MEK and ERK pathway inhibitors. So in conclusion, MEK inhibitors may still have a role. We just have to figure out the specific KRAS patients that will benefit from inhibiting MEK. Immunotherapy clearly has a role, both single agent and combination. And finally, we now have direct KRAS inhibitors, as well as drugs that can target KRAS at both directly as well as upstream and downstream. And we are learning also about the resistance mechanisms to these direct inhibitors. Sorry about action.
So I'm sorry, Shrish, I can't hear you at the moment, but thank you for that great presentation. Can you hear us? We've lost him. Well, I was going to ask a couple questions, but I think I'll hold until he gets back. All right. Next slide. Maybe when he gets back, we can ask him some questions. All right. So now we're going to move to small cell lung cancer, and Dr. Karim, you're up.
So, so basically it's the S1929, which called it clinicaltrials.gov, would be the testing maintenance therapy for small cell lung cancer in patients with SLFN11 positive biomarker. So SLFN11 is a predictor of PARP inhibitor sensitivity in small cell lung cancer. It was shown in a phase 2 trial that patients who are SLFN11 positive did have prolonged progression-free survival, 5.7 versus 3.6. And then compared to the SLFN11 negative, with overall survival benefit of 12.2 compared to 7.5 months when treated with the PARP inhibitor. So next. Taking probably a couple of seconds. If we can have the next slide, please. Basically, that shows that the PARP inhibitor, abelapurab, when given in addition to the chemotherapy temozolomide in relapsed and refractory extensive stage small cell lung cancer, there's an increased expression of DDR in small cell lung cancer with improvement in overall response rate in patients who received the PARP inhibitors and being in that group. Next. As a matter of fact, the DNA damage caused by the PARP inhibitors did lead to increased expression of the PD-L1. Subsequently, anti-PD-L1 inhibitors are supposed scientifically to have a better effect if combined with the PARP inhibitor. Next. So SLFN11 mediates deadly replication block in the context of DNA damage. As we see, the PARP inhibitors basically do have that specific role leading to cell death in the SLFN11 positive population. At some point, we will look into the SLFN11 negative and ATR and so on, but the upper part is our main goal here. Next. So the inclusion criteria for the S1929 is that patients who would be SLFN11 positive with no disease progression after receiving the standard of care of carbo, etoposide, and atezo with measurable disease by radiology, who have performance status less than 2, so between 0 to 2, with asymptomatic treated brain mets, weaned of steroids, and PCI and consolidation radiation therapy are permitted in our trial with normal organ function and no live attenuated vaccines within 28 days prior to randomization. Next. So basically, we estimate that 68% of the screened patients will be enrolled in the study. SLFN11 is present in 50% of small cell lung cancer patients. The estimated accrual goal is 84 eligible participants, 42 per arm, assuming 10% ineligible rate. That requires total of 94 participants accrued to be randomized. Estimated accrual role would be around 12 to 13 participants per month, and we expect 3 to 4 SLFN11 positive participants to be randomized to receive maintenance therapy each month. Next. Basically, I can have the most updated as of today. We had 18 screened and registered patients in our study. Basically, 11 of them are Schleffen-11 positive, 2 are Schleffen-11 negative, 1 insufficient tissue screen failure, and we're pending for the assay. So we do have 1 patient actively enrolled, randomized to Arm A in my institution. Next, I think we're done. Yeah, so challenges here, I would like to hear your opinion if the challenges would be for insufficient tissue. I think that also raises the question of the FNA and the biopsy, because the biopsy is the one that's needed in the study. Turnaround time of Schleffen-11 test results, eligibility criteria, or insufficient time between screening and randomization. And up to the poll.
It just takes a little bit here. There we go.
Sure.
So can you see it, Nagla?
Yeah, so I see 8% insufficient tissue. I see that 89% did not really see a problem. Turnaround time 4%. Turnaround time, I think really maybe the first 1 or 2 enrollments, but otherwise it's really coming through very, very smoothly. Even like our coordinators are so surprised. Wow, we send the Schleffen-11 and it comes over like very quickly. So I think it's the very same question of the FNA and biopsy, but we still need the biopsy.
Yeah. So not, I don't see any problems with it myself. I do think we do have to keep an eye on the FNA versus core, because it is, you're right, it's only for cores right now. I think we are considering working on the IHC for the FNA as well. Where does that stand?
I'm working with
yeah
I'm working
with them
at the MD Anderson, and we're trying to get that validated.
Right. So, but it looks like it doesn't appear to be too big of an issue at this point in time. All right. So I want to go back now. I don't think we have to actually go back to the slides, but I wanted to give the audience an opportunity to ask Suresh any questions about his KRAS presentation and see if anybody had any questions for Suresh. Let me go to the chat here as well. So Suresh, there is the phase 3 trial that's ongoing right now between sotorasib versus docetaxel in the second line setting. It's a randomized phase 3 trial with PFS as the endpoint of that study. And what do you think about that study, and what do you think about this drug getting approved without that? Or maybe we've lost him again. Well, I guess we've lost him again. He was having some issues there, so we'll talk to him later, I guess. All right, moving on to the next slide, please. Again, we do have some other questions coming, but we can't seem to get Suresh. I think he's having some audio problems here. And there are several other questions about combinations, about beyond D12C, of course, first line trials. All right, but getting to the final active trial, which is 1701 in thymic carcinoma. And I do want to say thank you all for really stepping up the accrual on this trial. I know it's hard, but last time we only had 2 patients and now we're up to 9 patients. So really, if you haven't opened the trial and can open the trial, please help us out. We need a goal of 60, but I have to applaud everybody who rallied around, and we called investigators to open this trial, and it has resulted in an increase of accrual. So we have 9 patients on, and we need about 51 eligible, valuable patients to continue this. So it's definitely moving in the right direction. So I truly appreciate that. Thank you so much. And then the next slide. We're at really the end of our day. So here's the last polling question, and everybody needs to answer this question, okay? Everyone should be able to answer it. It's a, will we meet in person for the SWOG spring meeting, April 21 through the 24th, 2021 in San Francisco? Will we meet in person? And everybody
you want a prediction about the future
yeah,
here?
Yes, everybody has to vote on this one. Yes or no? You have to be definitive. Yes or no?
We need to ask Fred. Fred's the expert.
It is kind of on the edge here, so I would say. Are we going for it here? We'll see. You know, we're supposed to have a vaccine like what, in the next, before the election, right? It's counting down. All right, so it looks like the answer is still no. So
that means we got to get Sharisha a better computer.
yeah. Well, overall, I think it worked well. So appreciate everybody being on the call today. And, you know, I think no is probably the right answer, but we can always be hopeful. We can always be hopeful there. So it's always nice to see the faces of those of you that are showing up here. And to the audience, thank you so much for participating. We actually are ending earlier than I thought we would. So that's a plus on a Friday afternoon. Does anybody have any last minute questions?
Just a last minute question. If the next meeting is open in person, is there an option to have also a virtual meeting for those who cannot attend? I think, you know, sometimes that can work. I'm not sure.
Yes, and I'm sure that that's also going to be considered. I didn't put the hybrid word because everybody would have just defaulted to the hybrid, I think. So I wanted, you know, just a yes or no, but I think that that's actually definitely going to be under consideration. And I suspect that we could see some type of a hybrid there. Anyway.
Karen, I think that's a great suggestion, because if we really want to open up the meeting to folks that are never going to be able to make it here physically, I think it's a tremendous option. All of our CRAs at our site were able to participate in the meeting today, and many of them have never been to a meeting before. So I think SWOG leadership really has to think very strongly about that for the future.
And you know, I think they are, because I think to your point, and when they assess the attendance here, I think they'll see that it's been positive. Yeah. And so I think you're right. I think you're right. Options are good. So anyway, everyone, thank you so much. I just want to end with, we have a lot of great trials, and please open them, please accrue to them. Let's move this field forward. SWOG, you know, I'm biased. We're great. And because we have a great team all the way around, we have a great community, We have great doctors, we have great staff, we have CRCs and our patients. We're just great. And but at the end of the day, we gotta accrue and get these drugs out there. And we also have to answer these other really, really important questions. The lung art question is something that's on every tumor board. So now we have an answer to that. The brain MRI versus PCI, these are great questions. They may not be as sexy as the drug questions, but they're still critically important for our patients. And let's just get all these trials. We've opened them all, and now we got to accrue to them all. And wouldn't it be great if we could accrue to them, before their accrual target goal? So thanks again, and be safe. Have a good weekend.
Great job, Ken.
Great meeting. Thank you very much.
Thanks.
Thank you.
Great job.
All right.